Okay, so let's get into endocrinology. First thing we're going to talk about is glucose homeostasis. What are some of the big hormones that are going to help us with glucose homeostasis? Insulin and glucagon. Those are two of the big ones. We'll talk about a few more a little later on, like GLP-1. It's another big one we'll talk about. We'll talk about dipeptidyl peptidase 4. It's really hard to say. But anyway, so we're talking about diabetes, right? So basically, we all need glucose. We all need energy, right? And you're going to find that there's some patients who either have issues of regulating this, maybe due to the fact they don't produce enough of their own insulin. We're going to find that especially patients who are maybe overworking the pancreas or maybe overworking their cells, you're going to find they become resistant to insulin. We're going to find some ways we can actually get around that with some of our medications here, right? So what happens if you have a lack of glucose? If your cells can't get enough glucose, what do they do instead to get energy? Start to break down protein. They also start to break down fats. They start to oxidize those. What can happen there? Yeah, you start to get ketone bodies, start to develop these acids there that can develop into DKA. Good. All right, so you guys know these pathways here. And again, with a lot of these metabolic syndrome patients, you're going to find they're really characterized by having this elevated glucose, right? By having this elevated glucose, what kind of problems can you see? Lots of problems, right? We see increased cardiovascular disease. We see more progressive atherosclerosis can happen here. We can see things like nephropathies, retinopathies, neuropathies, right? We talk about the macro and the microvascular complications of things like diabetes, which is characterized by this increased glucose levels, right? So again, you have a diabetic patient, type 2 diabetic patient, typically they're going to have kidney issues later on in life, right? And typically they have vision problems, right? They have neuropathies where they can't feel the sores on their feet. And then guess what? They have these nice diabetic ulcers that develop there, right? So there's a lot of problems having all this extra glucose, because again, who else likes glucose that grows on us? Bacteria, they love glucose. You have fungal infections. There are actually some drugs that can actually induce fungal infections a little bit. But again, these are things you have to consider having this extra glucose around, because again, it's going to be an energy source, not just for us, but also the stuff growing on us potentially, right? So looking at how we actually diagnose this, how do you diagnose diabetes? A1C is very useful. What does A1C tell us? Yeah, roughly it's like the average glucose levels for the past 3 months, right? So it gives us kind of a big snapshot there of kind of what the glucose levels are doing. What else can we use? Yeah, fasting glucose test, right? So it tells us kind of at baseline how well we're handling the glucose we have there. What else? How about like a pregnant patient? You can do glucose challenge tests, right? So you can actually see how they respond to these big boluses of glucose, so they're processing that appropriately, right? Polyuria, polydipsia, weight loss, those are all like classic signs of diabetes as well, right? So these are all things you're going to be looking for. And again, depending on your patient, you may have different goals for them. Typically, we like to see things, or for diagnosis purposes, things like random glucose above 200, fasting. Again, I'm not going to get specific on the diagnosis, but know what you're going to be looking for when you're especially doing monitoring for these patients when you're giving them drug therapy, right? So again, if they're being compliant with their drug therapy, you should see A1C go what? Should go down or up? Down, right? You should see their fasting plasma glucose go down, right? Good. So these know which way these things should be going when you're giving drug therapy. Know how the monitoring is going to go. Anyway, so again, with type 1 diabetes, what's their main issue? Don't make insulin, right? Why? Your beta cells suck. Yes. Or maybe they're not functioning very well. Maybe they're not there. Maybe they have an autoimmune condition that has now destroyed those beta cells, right? So now they can't produce insulin. It's a possibility, right? How about type 2 diabetes? What's their main issue? Insulin resistance, right? So that's the key difference here and why the drug therapy changes so drastically between type 1 versus type 2 diabetes. That Venn diagram overlaps a little bit on one drug in particular. What's that? Insulin. But you're going to find that for the majority of the issues with type 2 diabetics and insulin resistance, a lot of the drugs we're going to be using are trying to sensitize the body to the insulin that they're already producing. Now again, eventually those patients can wear out their pancreas and not producing enough insulin, but for the most part, they have plenty of insulin. It's just their cells are not using it appropriately because again, like anything, they start to downregulate and they're not going to be as sensitive to it anymore. Okay. Certainly there's gestational diabetes, and again, before you become diabetic, it's kind of that impaired fasting glucose sort of stage there. And obviously we know that especially like type 1 diabetes, renal failure tends to be a common cause of morbidity and mortality. Macrovascular disease like heart attacks and things like strokes are a big one for the type 2 patients. Okay. I'm not going to get into all that, but getting into the pancreas itself, so beta cells produce our insulin. Does it actually secrete insulin? It just secretes a proinsulin, right? Proinsulin eventually turns into what? Insulin, and then what else? There's another component to it. It's called C-peptide. C-peptide is actually something you can measure, right? You can actually measure that in the blood to see what the patient's actually secreting, how much insulin they're actually producing themselves, okay? That's one thing to consider there. As far as the alpha cells, what do they produce? Glucagon. What does glucagon do? Causes, it breaks down glycogen, so you get glycogenolysis, which feeds into gluconeogenesis, right? Where does it do that at? The liver, good, and that increases blood glucose, right? Which is important because we can actually give exogenous glucagon to raise up blood sugar levels, right? Get someone who's hypoglycemic, so we'll talk about that. I think like somatostatin. Anyone remember another name for somatostatin? Growth hormone inhibiting hormone, or octreotide, how I commonly think about it. Those are the main things we're going to be talking about here, but glucagon and insulin are the main two ones I want to focus on for these purposes here. And again, what happens when you have someone who goes into type 2 diabetes, you're going to find that they are overworking their pancreas. Their beta cells have just been working for too long, and eventually they say, we're out of here, we're done, we're not going to be secreting anymore, right? In addition to the insulin resistance, they're going to be developing over time as well. You tend to also find that patients with type 2 diabetes don't have very good responses to glucagon. Normally, what will suppress release of glucagon? Think about the negative feedback loop. If glucagon is designed to raise blood sugar levels up, what shuts down glucagon release? Hyperglycemia, right? When you get hyperglycemic potentially. When you eat, right? So normally when you eat food and you have ingestion of carbohydrates, that should lower glucagon levels. Well, what you're going to find with the type 2 diabetic patient is they don't respond that well to that. So their glucagon levels stay higher for longer, which is going to raise their blood sugar up even higher. Their insulin levels are not going to be where they should be, right? Because they're wearing out the pancreas. So again, these are a lot of changes you're going to find with these type 2 diabetic patients that we're aiming to try to reverse with some of our drugs. Maybe not reverse necessarily, but try to make maybe the insulin they're making work a little bit better in some cases. Okay, so the sensitization we're talking about. And so, when do you actually get that type 2 diagnosis? Is it right when the pancreas starts to wear out? Well, no, this has been years and years going on that you've been kind of wearing things out. And so you've lost probably about 50% of pancreatic function by the time most patients with type 2 diabetes actually get diagnosed, right? It could be much farther along than that, especially if they don't have good medical follow-up, but that's usually when you end up seeing it. So looking at type 1 diabetes, again, we know this is due to loss of those beta cells from the pancreas, usually due to some autoimmune condition potentially here. It's probably the most common one, but there are some idiopathic types as well that can happen there as well, but it tends to be a little bit more rare. Insulin itself, though, is what I want to focus on, is that it's going to be a protein that gets released, and eventually turns into insulin. Proinsulin gets released and turns into insulin and C-peptide. I'll show you a picture of what that looks like in just a second here. Again, what is the stimulus for release of insulin? Hyperglycemia, right? So again, blood sugar levels are high. It's going to stimulate release of insulin from those beta cells. I'll show you the actual process of how that occurs, because I'll show you where the drugs will actually be interacting there as well. C-peptide actually doesn't have any known function. It's just an index of insulin release. So we can measure that in the blood to see if, like, for instance, if you had someone who had recurrent hypoglycemia, and maybe you're suspecting there's an insulinoma, right? You have a tumor that's secreting insulin. You can measure C-peptide levels, and if those are high, then you know that could be the reason why that is, right? So things you can measure potentially. Not a routine thing, though. Anyway, so what you're going to find, there's an insulinase that actually will cleave that into insulin and the C-peptide, and that will then release. One thing to note here as well is that it has a fairly short half-life, but it gets cleared by the liver and then the kidneys as well. So who do you think might have an extended duration of action of insulin in the body? Patients with liver or kidney dysfunction. Predominantly what we find is that patients who are receiving insulin, if they have kidney dysfunction, that will stick around for longer and predispose them to what? Hypoglycemia. Is that a problem? What happens when you get hypoglycemic? You see lots of consciousness. You can see what else? Tachycardia. What else? So like the ultimate outcome. Seizure, coma, death, right? So it's always the caveat for a lot of things. Like what can ultimately happen? If you say seizure, coma, death, typically you're right in most cases, right? Yeah, so again, those are the things we're going to be, and we'll talk about hypoglycemia and symptoms and all that a little bit later on. But just know that patients with kidney dysfunction, they tend to have a longer duration of action of insulin, so you may need to adjust your dose a little bit to deal with that. If you're giving them what you think to be a typical dose that should work for them, but they tend to get hypoglycemic, it could be related to the fact they can't clear it very well. So what's the mechanism of insulin release? And I'll show you a picture to go along with this in a second. But basically, normally what happens is the pancreas, once it's exposed to increased levels of glucose, you're going to find that there's different glucose transporters. If you guys remember back in physiology, we talked about GLUT4, GLUT3, GLUT2, and all that kind of good stuff. Again, I don't really care that you know which one is which for our purposes here, but there's a GLUT2 transporter on the pancreas. And you're going to find that once they are transmitting that glucose into the beta cells, they get oxidized and turned into ATP, just like they do anywhere else, right? Once that happens, you're going to find ATP levels will go up. That then closes these ATP-dependent potassium channels. So normally potassium will be flowing out of the cell. Increased levels of ATP is going to close that. Okay. Well, by closing that channel, what do you think happens to the electronegativity of that cell? It gets more positive or more negative? Because potassium cannot flow out, it's going to get more positive, right? When it gets more positive, what do you think is going to happen? It's going to have an action potential. Good. So action potential occurs here. You're just going to find it depolarizes the cell, and then you're going to find calcium-gated or voltage-gated calcium channels are going to open up. So the voltage is going to increase. Calcium channels are then going to open up and allow calcium to flow in or out. Calcium is going to flow along the concentration gradient into the cell, just like in the muscle cells, just like in cardiac cells. Calcium tends to flow into the cell, right? Because normally calcium gets sequestered within a cell, so that way the intracellular levels are relatively low versus on the extracellular side. So calcium flows in these channels here, and then this actually will then stimulate exocytosis of these vesicles that actually contain the insulin itself. So calcium flows in, it's going to cause the exocytosis, and then that gets released into the bloodstream. Okay, this is important, this process here, because you're going to find that some of our drugs that actually stimulate insulin release are going to interrupt this process here, right? So when we talk about sulfonylureas, things like glipizide, glyburide, they're going to be directly stimulating or blockage of these potassium channels, which leads to that voltage-gated opening of the calcium channels, which leads to excitosis, right? So again, the picture showing you what's happening here. So glucose comes in, gets metabolized to ATP. That will then close these potassium channels. So potassium is not flowing out anymore. So this gets depolarized essentially. So potential goes up. It's going to cause depolarization. Calcium flows in, and that stimulates excitosis of these insulin vesicles. Okay. So if I have a drug that came in and directly blocked that, then that would also lead to that depolarization. Calcium comes in and then causes insulin release. Okay, so that'll be an important mechanism we'll talk about a little bit later. And it also tells you why that if insulin levels are low, that does not stimulate insulin release, right? Because if they're not being transported into the cells because there's not enough glucose around, you should not be releasing insulin at that point, right? Anyway, so how does insulin work once it gets around to the other cells? Well, GLUT4 is probably going to be one of the more common things you run into, especially like muscle cells and things like that, where basically you're going to be interacting with these tyrosine kinase receptors. It's actually going to cause, once insulin binds to those tyrosine kinase receptors, it'll cause glucose transporters to be transmitted up to the cell surface. They'll then allow that glucose to come into the cell. Once that happens, then it can turn into ATP and be used for energy for whatever process it needs to be used for. If you have excess glucose in the cell, what does it get turned into? Yeah, glycogen is going to be the most common storage source for that, right? We talk about glycogenolysis and gluconeogenesis. The reverse can happen when you have high glucose levels. Glycogen can be formed there, right? And again, this gets complicated, right? But just note here, here's the insulin receptors, one of those tyrosine kinase receptors. Once that gets bound by insulin, it's going to get phosphorylated, and that eventually is going to lead through a lot of complicated steps, which I don't really care about right now, but I'm going to lead to these glucose 4 transporters being put on the cell surface, and that will allow the glucose to come in to be used for energy or storage, okay? And what you're going to find is with those type 2 diabetic patients, they typically get resistant where those insulin receptors are maybe not as numerous or they don't respond as well to insulin. And so less insulin receptors there at the surface to be activated, less glucose transporters get on there. And so if they can't make it into the cells, where does all the glucose stay? In the bloodstream, right? And that's why they get hyperglycemic, because they can't transport that glucose into the cells there as well. Now, what about for a type 1 diabetic patient who doesn't produce their own insulin, and they can't get those glucose 4 transporters up to the cell surface? What happens to them? Well, the glucose doesn't get into the cells. They got to find an alternate energy source, and that's where you start to get that ketone production. That's how you get DKA. So even those patients who are hyperglycemic, their cells can't use that energy because they are insulin-penic, right? They have not enough insulin in order to drive that glucose into the cells to actually get that energy, right? So that's why they're reverting to other energy sources like fatty acids, proteins, etc. Okay, does that kind of make sense? So again, different problems going on here between type 1 and type 2 diabetic patients. We're going to find treatment may be similar between the two, depending on the case here. Anyway, again, for our purposes, I don't really care that you know the difference between these different glucose transporters. Just know that they are there. Just know that how they're going to be working to either allow for glucose to come into the cell, to allow for whatever action needs to happen, right? Whether it be stimulate insulin release, whether it be to cause the cells to actually generate energy, or for storage as glycogen. Okay, so looking at the effects, so depending on where you're at, you're going to find that this will have different effects here. So versus the liver, looking at the liver versus skeletal muscle versus adipose tissue, typically liver is going to be doing what with glucose? Mostly storage, right? You're going to find a lot of glycogenesis is going to be going on there, but it also can help with things like conversion of fatty acids, with forming things like VLDL, right? And so that's why we can see increased cholesterol levels associated with this. Normally, insulin should be inhibiting though glycogenolysis and gluconeogenesis. Okay, remember what normally stimulates this in the liver? Glucagon, right? Remember, glucagon is going to stimulate glycogenolysis and gluconeogenesis. Insulin is going to have the opposite effect, right? This is a seesaw sort of action you're going to see with this. In skeletal muscle, typically insulin is going to stimulate storage of glucose as glycogen, and also as amino acids as protein. So, is insulin catabolic or anabolic? It's an anabolic hormone, right? So if you ever look at like bodybuilders and stuff like that, they actually can use insulin. They're abusing insulin, I suppose, to actually work as an anabolic hormone, right? Because they're stimulating glucose intake into the cells, but they're also stimulating protein, amino acids into the cells to generate new protein, right? So that way they can beef up. That way they can look like Ernie. Huh? I don't know the specific dosing. Again, I try to stay off of those parts of the internet, but it is something that's been done, right? And so there's case reports of like bodybuilders who will come in very hypoglycemic, and it could be related back to them abusing insulin for the anabolic purposes there, right? But yeah, insulin is absolutely an anabolic hormone, just like anything else. And also, what do you think is the big side effect of insulin therapy? I'm storing all this glycogen. And if you here looking at the adipose tissue, we're storing fatty acids as triglycerides. What does that eventually turn into? Fat. So weight gain is a big side effect of insulin therapy, right? Which may not be great if you have a type 2 diabetic patient who's already overweight. Guess what they're going to do? They're going to gain weight. It's not the ideal thing, but it could be what they need because they may be insulinopenic, they may be resistant to insulin, may need the extra boost there. So again, side effects are going to be very important here. And again, I know I'm going to talk about this probably ad nauseum, but this is a really important sort of thing here because drug therapy is so varied here. You need to know what's going to cause what as far as side effects go, where certain drugs fit into place here. So this is why I kind of belabor these points here right now. Because if you understand the physiology of it, you're going to understand the side effects of the drugs, you're going to understand how they work better. Okay. So anyway, again, insulin is typically anabolic. It's going to cause weight gain. It's going to cause storage in the muscles. It's going to cause storage in the fat, etc. Again, if you have excess glucose, as these patients sometimes do, that's going to get stored as glycogen, right, and then eventually get stored as fat. Now, looking at insulin release in the body, now do we just constantly have a stream of insulin release that's constant throughout the day? No, right? It's going to go through certain rhythms to match what our blood glucose is essentially, right? Now, there's always going to be some basal amount of insulin being released. So always a small amount is being released throughout the day to deal with the normal blood sugar that you have at any given time, right? But we're going to find that there's going to be times where your pancreas is essentially going to give yourself a bolus of insulin. And what times do you think that's going to be? It's going to generally be around mealtime, right? So you're going to find that normally you have a basal insulin release here. Kind of see at the bottom. This is kind of like when we were talking about PCA pumps. You could have like a basal amount of drug being given, you give yourself a little boost. The pancreas is essentially doing this for you, right? So again, you have your big breakfast, you get a bunch of increase in carbohydrates and glucose levels. You're going to get a big spike of insulin here, right? Lunchtime comes around, you're going to get another spike of insulin. Supper time comes around, you get another spike of insulin. Any snacks that are in between there, you also get another spike of insulin, right? Which is appropriate because that's going to help to keep the blood sugar relatively the same, right? You will have a postprandial spike of glucose, but as insulin levels reach up to or build up to meet that need, levels will go back down to whatever your baseline is, right? So, and again, this is important because when we're looking at how we're dosing insulin, how we're giving it, we're trying to mimic this as best we can, right? So again, we're trying to basically take over for the job as a pancreas, and so we're trying to try to mimic this. So for instance, if I was to give insulin to a patient, say they're a type 1 diabetic, had no functional beta cells, how often do you think I'd have to give them an injection of insulin? It depends, absolutely, but at the bare minimum, how many would they think they would need? At least 3, right? Because they would need at least coverage for the 3 meals out of a day, right? Because when we know the pancreas is going to be stimulating that insulin release, we need to give them that insulin in order to match that. And I'll show you some examples of what that looks like in a second. Now, again, you're going to find that depending on if we're using long-acting formulations, there's a lot of different formulations out there. You may not have to do that. But again, I'm trying to give you at least the idea of how we're going to be matching what the pancreas is doing by using drug therapy. Okay, so kind of keep that in the back of your mind. Anyway, so we have a lot of different insulin formulations that are out there. It's probably over around 17 right now that are available, and you're going to find they differ in their onset of activity, their duration of action, how soluble they are, etc. How do you think most of these are being given? What route? Generally, so injection, yes, but what route specifically? Usually sub-Q. Typically sub-Q injection would be the most common way you give this. We will certainly give IV insulin on occasion. That's going to be more on the inpatient side of things, but sub-Q is the most common route, okay? Because again, they're proteins, right? They would just be chewed up by the GI tract, so we can't absorb those that way. And you're going to find that the profile gets altered based on several factors, right? Could be if we're changing the zinc concentration. So some forms actually have a longer duration of action if you include some zinc in with them. Sometimes if you're changing it by adding protamine into it. Now, where do we see protamine last? For heparin reversal, yeah, this is the same protamine essentially, right? So we can actually add protamine in with these drugs, and these are going to be longer acting. So if you ever see like NPH, it's not Neil Patrick Harris, it's going to be protamine containing insulin essentially, right? And then in some cases we'll have insulin analogs that try to mimic the natural amino acid sequence of insulin, but we change a few amino acids around, and by doing that you're going to find that changes the characteristics of it pretty dramatically, okay? So again, just be able to draw this out on the test, and you should be, I'm just kidding, don't do that. But again, looking at this, you're going to find that by changing out a few of the amino acids, we get very different profiles here. So we can either have things that work faster than regular insulin does, we can have things that work longer than regular insulin does, and that's going to change how we're actually going to be dosing these when we give them. Notice here we also have like things like bovine insulin. Why do you think they mentioned bovine insulin? Not necessarily. What do you think? So back in the day, before we could actually produce insulin, right, synthetically, we had to get it from somewhere else. So there's porcine and bovine products. Porcine being from where? Pig, and then bovine being from cows, right? So we would actually use animal products because again, we couldn't just, get donations of insulin from people. We couldn't synthetically form it on our own, so we'd actually have to get from animal sources. What do you think was a risk for using that? Anaphylaxis, right? Because again, you're giving a foreign protein. By changing the amino acid sequence, the body might recognize that it's a foreign product and might react to it. So again, we just mentioned this here because we used to use animal sources for this back before we had ways we can synthetically make this, right? So the forms we have now are all synthetically formed, either using like E. coli or using yeast, whatever the case may be, but we can form basically human insulin that is identical, or we can kind of modify it a little bit to get different release profiles, okay? So something to think about here. Some of them might have something like a fatty acid chain added to it, and that can actually help to extend the duration of action, but we'll go over all those characteristics here in just a little bit. So, as I mentioned, we have different formulations here. Again, you may be able to get pork-based products on special order, but it's very rare you'd ever see a patient use it. I certainly have never seen it. But again, it's what we used to use back in the day. Beef, it was very antigenic. A lot of people had reactions to it, and it's very problematic, right? So now we either have recombinant forms that are basically mimicking the human form, made in E. coli and yeast. So this is where we have things like Humolin, that is made with E. coli. We have things like Novolin made with Baker's yeast. These are just different manufacturers. There are brand names for this. I don't really care, the brand name specifically, but just know that, when you look at different dosage forms, you may see like Novolin, Humolog, Novolog. That's basically what it's just saying. Is it's a different brand name, different manufacturer. Okay. Any questions from last time? Anything we covered? All right. So moving on, we were talking about different types of insulin. I actually have a good story from yesterday when I was working of a potential medication error that was narrowly avoided. Related to some of this stuff. But anyway, so getting into it, we have a lot of different forms of insulin that are out there. A lot of the different varieties have to do with their kinetics of the drugs, right? So again, how fast they're going to be working, how long they're going to be working for, all of that. So for instance, we have things like ultra short acting insulin. These are going to be things that have very fast onset. I'll show you a graph in a few minutes here that demonstrate how they what their onset is, how long they last, etc. So we have really short acting. So for instance, we have insulin Lispro, Aspart, Glulisine. There's a table later that has the brand names associated with those. But be able to identify which category these fit into, whether it's regular, long acting, short acting, etc. So be familiar with these as we go forward. These are going to be ultra short acting. So very fast onset, very short duration of action. When do you think these would be good to use? Around mealtime, absolutely. Why are they good around mealtime?
So you can uptake that glucose for yourself.
Right, so when we eat, we have a lot of carbohydrates that are coming into the bloodstream. We want something that's going to be fast acting in order to simulate sort of the bolus effect that we get from the pancreas sending out a lot of insulin all at once in order to drive that glucose into the cells. That way we can use it for energy production and all that good stuff. So those are good around that time. We have short acting, which we'll consider to be regular insulin, which we call that. When you say regular insulin, that's what we're referring to. And again, this is exactly what we're producing ourselves, right? So when you see regular insulin, it's just the same stuff that we produce. Next, we'll have intermediate acting insulin. This is an NPH. It's actually a form that has protamine in it. That has a little bit more of an intermediate sort of acting effect. Now, when do you think we'd want a longer acting form of insulin? When do you think that'd be useful? At nighttime, okay. Maybe when the patient is not having any active intake of carbohydrates, you know. So again, it gives us a nice stable effect throughout the night. What does that kind of simulate from the pancreas? Yeah, basically basal insulin release, right? So again, when you look at your long-acting forms, you're going to find these are trying to simulate the basal amount of insulin being released from the pancreas throughout the day, right? 24/7, your pancreas is sending out some amount of insulin. This is going to be mimicking that, right? So again, we're looking at this basal bolus sort of approach, very similar to what we saw with like patient-controlled analgesia. Remember when we looked at our PCAs, you'd have a basal amount of, say, Dilaudid that would be being infused into the patient, and they can give themselves a bolus when they're having additional pain. Similarly, with this stuff, you're going to find that you'll have long-acting forms that provide that basal coverage for that blood glucose to keep it in check. And then when you have big boluses of sugar coming in, that's when you're going to have those short-acting versions that come along and will help to get the blood sugar back under control. Okay, so I'll show you some graphs that kind of illustrate that. We have really ultra-long-acting forms as glargine, detamir, and degludec are the three that fall into this category. Again, longer duration of action usually means you have to give it more or less frequently. Less frequently, right? So for instance, with the NPH insulins, or like the ultra-lente, the long-acting, and the intermediate, those are usually twice-a-day insulins versus something like the ultra-long-acting, only one-time-a-day insulins, which are nice from a compliance standpoint. Because the ideal thing, how many injections do we want to give these patients a day? As few as possible, right? So again, that would be ideal. If we can do fewer, it's going to be better for these patients. And then there's even an inhaled form. So how do you think we have an inhaled form of insulin? Does that make any sense? It's not real. It is real. There's a real thing. This is a Freza. Basically, they've been able to kind of engineer it such that we do have some amount of bioavailability from inhaled insulin, right? The stomach doesn't work because you worry about all those proteases and things chewing up that insulin. But there is an inhaled form. This is better for like short acting, and you're going to find relatively few number of patients who are actually on this. What do you think is the benefit of inhaled versus more traditional forms of insulin? You have to take a shot, right? You don't have to, well, not take a shot, but like actually inject yourself. You're going to find that by inhaling it, there's some benefit there from a compliance standpoint, right? And maybe more palatable by the patient. So looking at the different profiles here, again, you'll get an idea of what their onset is, what their duration of action is going to be, etc. And what you notice with the short-acting insulins like Lispro, Aspart, and Glulisine, they have a very intense sort of onset of effect, but they peter out pretty quickly. Within a few hours, you should really see no more effect from that drug itself. Okay, versus something like regular insulin, you're going to have a lower peak. It's going to be more delayed. And this is important because you have to figure out, well, where are you going to time these insulins out in response to your mealtime? So for instance, something like insulin glulisine, you can maybe take 15 minutes before you eat, versus something like regular insulin, you may want to take a little bit longer before that, maybe 30 minutes before you eat, right? Maybe 45 minutes, because we know there's going to be a little bit more of a delay in onset for those insulins. Okay, NPH, you're going to see here again, it's going to be more of a Q12 hour sort of insulin. There has a little bit longer duration of action, not so much of a peak here. And with the really long-acting forms like the detamir and the glargine, you're going to find that these have really no peak effect whatsoever, but they have a very long duration of action. And so they're going to mimic that basal effect of what the pancreas would be releasing throughout the day, just with a long-acting form of insulin. Okay, so get a good idea for how these different insulins are going to be working, because again, when you're designing a regimen for your patient, you have to figure out what's going to be appropriate based off of, is it short-acting, long-acting, how do you combine them together? Okay, we'll cover that in a few minutes here. So there's different ways we can have the insulin actually be administered. We have injection, which we mentioned is conventional, right? It's the typical way we're administering this. And again, it's a sub-Q, IM, IV, sub-Q typically, right? There's portable pen injectors. So if you ever see like the pens they have there, it actually has a dial on the end of it. You can actually dial up the dose, specific dose of insulin you want to administer there. Have little pen needles you put on the end, and you can inject that. What do you think are some limitations of using like either traditional injectable, where you actually drop a dose in a syringe, or one of these pens? What'd you say? Yeah, think about the dexterity aspects there, right? Are they actually able to coordinate and actually inject themselves and press the button? It may seem like it's a simple task for you and me, but for some older patients, think patients have rheumatoid arthritis, etc., it could be more difficult, right? What else?
calculate how much they need?
Yeah, so and how do you think they calculate how much insulin they're going to need? All right, so things like sliding scale. So what is a sliding scale?
How much you each take or how many carbs you're eating?
That's more of a carb. So okay, so it's a little bit different, and there's a little bit of ambiguity there. There's kind of two main ways you can do it, right? So and I think I talk about this a little bit later on, but there's carb counting specifically where you kind of figure out how much carbohydrates you're actually intaking, and then you figure out insulin dose based off of what we call insulin sensitivity factor. And again, who do you think is going to be more sensitive to insulin, a type 1 diabetic or type 2 diabetic? Type 1 diabetic, right? Because they haven't really been releasing a whole lot of insulin for the majority of their life versus a type 2 diabetic. They've been running their body ragged from that standpoint. They're very resistant to insulin, right? So you might see insulin sensitivity factors vary quite widely between those two. And I'll show you what typical doses look like between a type 1 versus a type 2 diabetic, and you'll see how greatly they differ there. The sliding scale is more or less when you actually take a blood sugar measurement and then you see where you're at, and based off of that, you give yourself a correction. So for instance, if you check a blood sugar and it comes up as 300, it's a high or low? That is high, right? You'd say, okay, well, for 300, level 300, I'm going to give myself 4 units of insulin. For level 400, I give myself 5 units of insulin. So because it's a sliding scale based off of the actual glucose checks, that will dictate what dose you actually give. So that's easy enough because, again, it'll just have like a scale of numbers you'll actually administer the insulin dose off of. The calculation comes into it when you're actually doing the carb counting, which can be a little bit more fraught as far as the math goes. Because, again, typically you're looking at how many carbohydrates you're taking in. You have to factor in the insulin sensitivity factor and all of that. So, again, there's a decent amount of math. But just yesterday I was checking a 9-year-old who was doing, she had a sub-Q insulin pump that she was on, and so one of our things we do if we're going to let a patient kind of control their own insulin, because is insulin kind of a high risk medication? Absolutely, it's very deadly, right, in the wrong hands. And so, she's 9-year-old, and I went up to talk to her, and our goal is to make sure that she's competent to use her thing. And so I was talking to her, I was like, okay, well, what's your insulin sensitivity factor? How do you do your carb counting? And I mean, she was like just running through it like it was just nothing, like it's just second nature to her. So it's really cool how these little young minds with all their neuroplasticity are able to deal with these really complicated disease states much better than I probably ever could, right? So they're very, very smart when they get to having to deal with these chronic conditions. But anyway, right, so the math could be difficult there. Also, just think about the dexterity. Has anyone actually ever drawn up a medication out of a vial? There's some dexterity you have to have with that. And so training is really important. That's where your diabetic educators are going to be super helpful in helping with a lot of that. Next, we mentioned the continuous subcutaneous infusion or the insulin pumps. Now, again, this is one of the first insulin pumps that ever came out there. Kind of looks like you have like one of those ecto packs from like Ghostbusters or something, right? From a compliance standpoint, do you think this would be super great? No, not good. However, now this is what they now look like, right? So I mean, like they're very, very tiny pumps you can just attach to the side of your pants, and then you'll have a catheter that'll be running, and this will be in place subcutaneously. And so, what type of insulin do you think is going to be contained in one of these? Think a long-acting, short-acting? I know you know all the answers already. Why do you think short-acting? Did it? Well, if no one else answers. So why short-acting? Why do you think we would want? I burned my one bridge, now I don't know when to answer questions. I'm just talking to myself.
I guess it's just because you're consistently eating throughout the day, so it makes calculations, is what I'm assuming.
That's a good thought. Not quite. What do you think? Yeah, that's one thing, right? So one of the things you're going to find is anytime you have a continuous infusion of a medication, you want short-acting medications because you want to be able to titrate that dose as you need, right? So if I use a long-acting medication that has a duration of action of 24 hours, and I need to titrate that dose, it's going to take at least 24 hours or more for that new dose to really kind of kick in and take effect and all of that. That's not really what we're looking for with this. We want very acute sort of management of our glucose. And so what these will do is they'll actually have a basal amount of short-acting insulins that will release. It could either be regular, or most of the ones that I see are either like a Humolog, a Novolog, like the Lispro or the Aspart. They'll have a short-acting insulin in there, and they'll have a continuous basal amount that will be releasing. Right, so that's the part of that basal amount of insulin simulating what our pancreas would normally be releasing. And then as they have carbohydrate intake, they'll actually program into the pump and they'll say, hey, I'm having this many carbohydrates. Their insulin sensitivity factor is already built in, or they program it in. And they'll say, okay, here's how much I want to get. Or if they check a random blood glucose and it comes back high, they can program in a bolus on how much they want to give themselves. So by using short-acting insulin, you avoid that dose stacking sort of effect as you would get if you were using, say, multiple doses or a continuous infusion of a very long-acting sort of insulin there. Okay, so that's really important to consider. Is you want to have short-acting insulin for those continuous pumps. And anytime you have a continuous infusion of a medication, whether it be a vasopressor for blood pressure support, whether it be for, I'm trying to think of anything else as a good example. those are the big ones. You want to have something short acting, so that way when you dial up the dose, you're going to see the effects really quickly, and if I need to dial down the dose because the effects are too much, then that will come off very quickly as well. Okay, it's kind of a general rule of thumb there. And then, so there's the inhaled form. It's actually a dry powder specific inhaler. I'm not going to talk about this too much because, again, I don't really see too many patients on it. I remember there's one other form that actually came out while I was in school that no one was buying, and so it actually went off the market. And so this is actually the newer one. Again, I don't see too many people using it. So here's a table kind of showing you the different forms, and again, be able to recognize them based off of their activity. So be able to recognize an ultra short acting versus a regular versus long acting forms of insulin. No, you don't have to worry about the vial sizes and all that. I just wanted to get you familiar with seeing kind of how these are available. They either come as an actual vial that patients can draw up doses themselves, or more often than not, you see a lot of patients that get put on the pen cartridges, so that way they can just dial in the dose they need, administer it to themselves, and then they're good to go from that standpoint. So again, we have our rapid acting insulins, we have our short acting, which is regular insulin. Now when you see this U100, what do you think that means? U probably stands for units, right? Because how do we dose insulin? It's dosed in units. It's not milligrams or micrograms, nanograms, it's units, okay? So U100 probably means is U, and the 100 probably has to do with what? Or the concentration of the drug. So when you see U100, that means 100 units per ml, okay? So just a handy thing to keep in mind. That'll be important because there's things like U500. U500 would be how many units per ml? Probably 500, right? So because of that, what happens? What do you think would happen if you actually screwed that up and gave someone U500 instead of U100? You would kill that patient, right? Because again, it's 5 times more potent than what you would expect. Now again, you could reverse it. You could try giving glucose in order to fix that, but that's not an area you want to get into, right? It's a really big high risk area that we try to avoid, especially in hospitals. Why do you think you need a more concentrated form of insulin? Probably for patients who need really, really big doses. So if you find these like type 2 diabetics that have like very high insulin resistance and they're getting like dozens and dozens of units in a dose, like that's going to be, these patients are getting like the U500. So be very wary if you ever see that. You don't want to use it unless you have a really good indication to U100. And most of these are going to be that concentration of 100 units per ml. Mainly because when you have these dosing syringes, they actually will dose it based off of the units. So you'll know exactly how many units you're drawing up to based off that standard concentration. Okay. And then we have things like the NPH, these are going to be more intermediate acting. So if you ever see an N on an insulin, that just means it's going to be the NPH intermediate acting forms. And then we have the long acting like Lantus, Levemir, and then Tresiba. So these are going to be your very long acting, typically given 1 time a day, maybe twice a day, very rarely, but for the most part 1 time a day dosing. Okay. Now we also have some mixes here. So what do you think of the benefit of using a mix? So for instance, this one has a mix of the neutral protamine insulin, which protamine we mentioned is that NPH form, and then Lispro, which is a short acting. What's the benefit of using the intermediate plus a short acting together? Well, if I take it, say, as my first dose of insulin for the day and I take it right before breakfast, I have the short acting form that's good for that breakfast meal coverage, right, for that glucose, and then the NPH is going to be able to cover me for several hours after that, right, for basically the next half of the day or so. So maybe one indication, the goal of mixing different insulins together is to do what? Decrease the number of injections you got to give yourself, right? So again, fewer injections is better from a compliance standpoint. So that's why you see sometimes these mixes. Now again, now that we have more of these long-acting forms that are available, I don't see these used as often, but occasionally you may still see it depending on the patient there. Here's a mixture of NPH and regular insulins. Here's the concentrated forms I talked about. So U500. Again, 5 times as concentrated as what the normal regular insulin would be. U300, 200. So again, you be very, very careful anytime you're dealing with these. And again, using a U there can be sometimes error prone, so always write out what? If you're writing a prescription, units, right? Always write out units. You don't write international units, that's too long. Just write units and people will understand what you're trying to talk about. Okay. And again, you have Afrezza, and again, whoever named this, kudos to them. Technosphere insulin. I mean, like, who wouldn't want to take that drug? Sounds awesome, right? But again, I don't see too many people using it because, again, probably cost is going to be extremely high for this as compared to typical insulin doses. Not that insulin is cheap, right? Because, again, this is going to be stuff that patients have to have, and they are a lot of times recombinant forms and things like that. So they're not cheap in and of itself, but they're a heck of a lot cheaper than something like this inhaled form. So, and again, you don't need to know the specific onset here, but again, you have a general idea of how these different insulins will compare to one another, the rapid acting versus the short acting versus the more long acting. Notice here that these are not really going to have a peak, right? Because they have that nice kind of plateau sort of effect, have a nice basal sort of effect, as opposed to something like an Aspart or a Lispro. You're going to find very intense, fast-acting effects, very high peak effects, but it trails off very quickly. Okay, so those are things to kind of consider. If you ever see cloudy insulin, now normally if you see something that looks cloudy, would you want to inject that into yourself? Not typically, right? But actually with the NPH, it actually has a cloudy sort of shade to it. That's important in a second because I'll tell you a little trick about mixing insulins together. Most of them, they should be clear though, for the most part. So anyway, so again, what's the biggest complication of using insulin? Hypoglycemia, right? That is the most common thing. That is the most life-threatening potentially thing, depending on how hypoglycemic the patients get. What do we consider to be hypoglycemic? Less than, yes, 60, 65, somewhere around there. So less than, what's the units on that? Anyone know? Milligrams per deciliter, right? So between 60 and 65 milligrams per deciliter, that's considered, below that, considered to be hypoglycemic. So again, be careful, especially if you were to get one of these mixed up and give the wrong one, they could definitely have that occur. Now you are injecting proteins again, so you can see some immune response to that. So either you can have an actual allergy to the insulin. So sometimes you'll have patients that'll say they're insulin allergic, and you're like, well, how is that possible? Like, the patient would be dead. You got to have some kind of insulin. Oftentimes it's going to be to another component actually built within the insulin. So for instance, some people have a protamine allergy. It says they're insulin allergic, but really they're just allergic to the NPH form of insulin because of the protamine there. So you have to do a little bit of digging to figure out specifically what their issue was with it. Sometimes you actually have an insulin resistance that develops because you'll have antibodies that will actually go in, actually neutralize that insulin before it has a chance to interact with your cells. So again, sometimes it can be overcome with bigger doses, sometimes by switching to insulin, that's you can overcome that, but that's something that can occur in some cases there. And then the other big thing is you're going to find some injection site reactions. It's no fun to have to inject yourself with products here, but it's important to make sure that we warm up insulin beforehand, right? So try to roll it in your hands for a little bit, make sure to warm it up before injecting it. That can sometimes help with that pain associated with that. And you want to make sure you're rotating sites, right? Don't inject the same site every single time because you're going to get some fibrosis there. You can have lipodystrophy that can happen, so you have to rotate sites around, okay? Now, as compared to something like a sub-Q pump, like they'll have a catheter that's in place and they'll just stay there for a while. I'm not sure how frequently they change that. I think it depends on the patient situation and the different products. But again, that could be a different feature there. But you really should be rotating sites around the abdomen. That's the most common place because, again, just technically it's easier to inject yourself in the abdomen versus anywhere else, right? And then weight gain is going to be another big one. Typically, type 1 diabetic patients, are they typically pretty overweight, underweight? If you think about the pathology there, right, they don't have enough insulin, they're not getting glucose into their cells, they're not using that glucose to produce things like fat, they're probably underweight, right? You think about the triad of symptoms you see with diabetes, it's what? Polydipsia, polyuria, weight loss, right? That's the third one, right? So again, those are things you're going to expect to see based off the fact that they don't have that glucose coming into their cells. So by giving insulin, now all of a sudden we're transporting that glucose into the cells. What's going to happen? Gain weight, right? Insulin's an anabolic steroid, just like any other of these hormones here. The anabolic hormone, not steroid specifically, but a hormone, it's going to cause weight gain to occur there, okay? So drugs that can maybe decrease the hypoglycemic effect of insulin. So these are things that maybe your patient's blood sugars are running high and you're like, why the heck are they not really working that well? Is it because the dose isn't adequate? Sometimes it could be due to drug interactions. So for instance, if I have someone who's on a sympathomimetic, right? So say that for instance they were taking Sudafed for, say, congestion due to a cold or something like that. Well, by stimulating the sympathomimetic system, right, the sympathetic system, what does that do to the liver in terms of glucose? If you're in a higher fight or flight sort of response, you want to have gluconeogenesis, right? You want to have glycogenolysis because your body's in that fight or flight mode due to that medication. It's going to say, hey, we need more glucose around. So what does that do to your blood sugar? It's going to go up. It's going to make the insulin not work as well because you have higher blood sugars to deal with, right? Things like that you're thinking of. Thyroid hormones. Again, the more thyroid hormone you're on, if you're in a hyperthyroid sort of state, again, that's going to be stimulating your metabolic system. That's going to cause blood sugar levels to go up. Corticosteroids. We know corticosteroids tend to have hyperglycemic effects already. So again, that's going to make that worse. Or contraceptives can make this worse. So just be aware. Check in to see what kind of changes have been occurring. Obviously, when you have a patient as well taking insulin, the big question you always want to ask them is, are you taking it like you're supposed to? You're actually injecting yourself that 4 times a day, that 3 times a day you're supposed to. Some patients may not be doing that, right? They're like, well, I'll just do it twice a day and I'll see what I can get away with, right? And so sure, maybe there are random glucose checks they do after they get the insulin looks good, but what else can you check to make sure they're actually running correctly for a longer period of time? A1C, right? So you get that nice 3-month sort of snapshot there to see kind of what they've been normally running there. So they're normally running high, their A1C is still elevated. Maybe show that they're either not compliant or there could be something else going on to make that blood sugar high. Okay. Things maybe increasing the hypoglycemic effect of insulin. Alcohol can do this, right? Alcohol can actually deplete glucose stores within the liver, can actually predispose you to hypoglycemia. I'll never forget one time I was in undergrad in college, and of course I didn't have any medical knowledge at the time, but I remember one of the people that lived in the dorms nearby actually was a type 1 diabetic patient who was taking insulin, or insulin dependent. I remember seeing them at a party one time, and they were just doing tons of shots, and I was like, I don't know if that person should be doing that. Like, this seems very ill-advised. I was not very fond of parties, as it turns out, but she was at risk for having hypoglycemia, right? And again, what other effects do you see? How does someone with hypoglycemia present potentially? Like they're drunk, right? Okay, so now all of a sudden, can I tell, is it because they're hypoglycemic? Is it because they're drunk? It's hard to tell between the two. And obviously, which one could be potentially more life-threatening? The hypoglycemia, right? So again, I don't know which one is which, and so sometimes that can be a little bit of a clinical conundrum there. Yes, sir?
Sometimes when a person sees ketosis, their breath smells like beer.
Mm-hmm.
It's a very fruity odor.
Mm-hmm.
So not everybody that comes in smells like Budweiser is actually drunk.
That is very true as well, yeah. So again, those are things we can check on. And so again, sometimes people just like fruity beers, you know. There's nothing wrong with that, okay? That's all I'm saying. That's the thing we run into a lot with kids, especially if kids get into alcohol. So for instance, if a child would accidentally drink some isopropyl alcohol, or they get into, you know, dad's beer or mom's wine or something like that, that's one of the things where it's like, okay, well, a drunk toddler is funny enough on its own, but I don't actually know if they're, you know, ataxic because of the alcohol or because they're more predisposed to hypoglycemia as well. So that can be a concern as well. If we have people call up the poison centers and say, oh, little Johnny got into some Four Loko, let's say they have that line around the house. Right, we'll tell them actually drink something sugary along with that. The Four Loko is probably sugary enough, but drink something sugary along with it, so that way you at least take the hypoglycemic concern out of the picture there. So that way if they're acting drunk, it's probably just because they're drunk, as the case may be. Anyway, so that's one example. Other things like anabolic steroids could also increase the hypoglycemic effect, beta blockers. Now beta blockers are interesting because what are some other signs and symptoms of hypoglycemia? If your body detects blood sugar levels are low, how does it respond to that? Well, it says we need more glucose, right? So what is going to be secreted? Glucagon's one thing, right? So you're going to secrete glucagon because you need to increase our blood sugar levels. What else gets stimulated? Well, the sympathetic nervous system is going to get stimulated, right? So again, what are the signs and symptoms of hypoglycemia? So you mentioned the lethargy, you mentioned the ataxia, what else? Diaphoresis, palpitations, they get tremors, right? They get very hangry, right? So because of that, if you give a beta blocker, some of those effects are going to be blunted, right? So you can actually blunt the diaphoresis, but the diaphoresis. You can blunt the tremors. You can blunt the palpitations, all those things that go along with that. So what we talk about with beta blockers in diabetic patients is it can mask the signs of hypoglycemia. We've talked about this before. But again, now we're starting to see why that is in terms of these diabetic patients. So again, by masking those signs there, they could be hypoglycemic. They don't know it early enough, and they may not be able to respond appropriately, right? Because if someone's hypoglycemic, and they're still with it, they can take oral supplements and get back to baseline. However, if they kind of let that progress because the beta blockers masking all those signs that they don't know they're hypoglycemic, that's where they can run into big problems, right? And that's where you might need more parenteral therapy. You might need, call it 911, whatever the case may be. Okay, so just things to consider. So what are indications for insulin? Typically, type 1 diabetic patients are going to become insulin dependent because they are not secreting enough of their own, right? A lot of times, how do we diagnose patients with type 1 diabetes? You can do that, but sometimes, and I always think from the emergency medicine standpoint because that's just my background. But sometimes people present the first time in DKA essentially, right? So again, either they got a cold or something, they kind of just threw them for a loop, or they finally just kind of run out of their own insulin supplies and they come in full net DKA, right? So again, they automatically become insulin dependent at that point, and so that's a big indication there. Also we talked about for pregnant patients, fewer drugs is better. Typically, if we can give them something that's very natural to what the body's producing, we can use that for diabetic patients who, either pregnant women who have type 2 diabetes or if they develop gestational diabetes. If they can't do it with diet alone, oftentimes insulin can be used there. Now, type 2 diabetic patients that they are not managed with just diet, exercise, and medications alone, that's again, we're going to start to initiate insulin for them, and we'll talk about those other therapies a little bit later. DKA, hyperglycemic, hyperosmolar non-ketotic syndrome. That's kind of something that happens with type 2 diabetic patients. You're going to find that they develop that. And then hyperkalemia. I think hyperkalemia can be an indication for insulin. We'll talk about this more a little bit later in the emergency medicine section, but this is actually something where there's a common cocktail that people with hyperkalemia are going to receive, and insulin and glucose are actually one of those, because it actually helps to drive potassium into the cells. By giving insulin and glucose, it will drive that potassium into the cell and hopefully help to shift potassium out of the blood and hopefully not aggravate the heart quite so much and see less of those arrhythmias happen there. So again, it's another indication we see insulin being used for a non-diabetic patient. It could be those cases of hyperkalemia. So insulin regimens, again, they have to be tailored to the patient's lifestyle. If it doesn't fit the lifestyle, they're probably not going to be real compliant with that. And so very frequently, though, what we're going to have is this basal bolus regimen, and that's going to be also based on their self-monitor blood glucose readings, right? It's not only to stick yourself with the insulin, you got to stick yourself with the glucose checks frequently, many times throughout the day. Always think about that the BB King commercial where he's talking about can't play guitar anymore because they have to stick his fingers all the time, right? You know, it can be kind of problematic, you know, depending on what their lifestyle is, what their hobbies are, etc. Oftentimes they're either going to need multiple daily injections, or for some patients they can get away with using these subcutaneous infusions. Now, what do you think the caveat is with using subcutaneous insulin pumps? Patients really got to be with it, right? So they really have to have a good rein-in on what their insulin dosing is like. They need to have good experience with this. They need to make sure they're really going to be compliant with it. You don't want someone who's going to be non-compliant having this insulin pump that may be going when you don't want it to be going, etc., because that can lead to some big problems. So you typically want to have someone who's really with it. Obviously, you know, a 3-year-old, got to put them on a sub-Q pump? Probably not. They're not really going to understand how to use that stuff. But a 9-year-old actually is with it enough to actually to do that, right? So I just talked to one yesterday who was able to walk me all the way through a regimen, tell me more about her diabetes than I could, right? So again, it just depends on the age of the patient, what their mental status is, etc. Typically what you're going to find is that the more frequent insulin administrations you're giving, the tighter the glycemic control is, which is good from one standpoint, but you're also going to have increased complexity. You're going to have more chances for what side effect? Hypoglycemia, right? The more I'm giving, more likely I am to see the hypoglycemia. Less often, though, you're going to find that you will have less chance of hypoglycemia, but also less tight control of the glycemic index, or the actual glycemic profile for that patient there. So again, you have to find a happy medium between the two, so that way you're not having to give 7-8 injections throughout the day, but you're also not just giving one time a day, right? So different ways we can do that. We can try to match carbohydrate intake with insulin and physical activity. What do you think physical activity does to your insulin requirements? Does it increase it or decrease it? Usually decreases it. Why? Yeah, you're using up your own glucose, right? Your cells are going to be able to use that up, and so you have to take that into account. You know, if you're going to run a marathon, like maybe you don't need as much insulin for that day, right? If you're going to go work out or something, you know, if you're going to have, depending on your mealtime intake of carbohydrates, you have to have a good idea of how many carbohydrates you're intaking to know how much insulin you're going to need for that, right? And again, the goal is to try to get as kind of a normal lifestyle as possible for these patients there. And so ideally, the insulin administration will mimic the pancreas as best we can. So that's why you have the basal insulin going on top of the bolus doses that are going to be given throughout the day. Or in case of something like a subcutaneous pump, you're going to have the pump releasing that short-acting insulin continuously throughout the day, but it'll have its own boluses again, you know, for meal times and things like that. Okay. And again, usually you're going to find that twice daily injection just isn't enough for a lot of patients. They're going to need much more than that, probably at least probably 4. Probably at a minimum in a lot of cases, but we'll see some different regimens on what those look like. Okay, so again, looking at insulin release, normally we're going to find that here's your basal insulin amount that can be released here versus the glucose in the body, right? And because, you know, what's a basal glucose in your bloodstream should be? It should be like 0. No, because you'd be dead, right? You need some amount of glucose in the blood. So, you know, usually 80 to 100, something like that. So you're going to have a basal amount of glucose, but again, that glucose will spike up in relation to mealtime, in relation to exercise, things like that. And so again, this is what we're trying to mimic, is giving insulin to match that, to keep the basal glucose at a normal level, and then to give insulin to match the intake of that carbohydrates to deal with that, so that way we don't stay hyperglycemic for a long time. Okay. Again, you're going to find that the insulin doses will change depending, again, on the carbohydrate intake and also on exercise. We kind of talked about how that's going to differ. So again, if you're, say, going to have a salad versus, say, a fried donut, which one do you think you need more insulin for? Probably for the donut, right? So again, the patients will have to get pretty good at being able to determine kind of what the carbohydrate you know, content is going to be of that food there. Again, that's where, you know, a lot of tracking apps and things like that can be very useful. But in the food, say, hey, I'm going to go eat at, you know, Olive Garden would get this. They're gonna say, oh, you need a lot of insulin. Because Olive Garden, you get the bottomless breadsticks, like you're gonna be needing some serious insulin there. I'm just kidding. But sometimes apps can be very useful for tracking carbohydrate intake. And so as I mentioned, we have the sliding scale. Again, this is going to be sliding based on the preprandial glucose reading. So you'll give yourself a certain dose depending on what that level is at that time. And then we'll talk about correction factors and how we'll figure out how much glucose you'd expect to see change based off of 1 unit of insulin being administered, right? So someone who's more resistant to insulin, you're going to find that amount of glucose change is going to be smaller than someone who's going to be more sensitive to insulin. You're going to find it's going to cause a bigger change. All right, so that's the insulin sensitivity factor we're talking about. And then the carbohydrate counting is going to be based off of the anticipated carbohydrate intake. So if I'm getting, say 40 grams of carbohydrates coming in this meal, then I need this many units of insulin based off of correction factors, right? So here's some examples of different strategies for dosing insulin for these patients. Let's say here's a normal plasma glucose concentrations. Here's a patient, what this would look like if you had, say, a normal functioning pancreas, no insulin resistance whatsoever, right? Now, looking at normal plasma insulin concentrations, you'll see how, again, you have a basal amount, but it will spike up around those meal times. That makes sense. We've already looked at this before. So let's look at some insulin regimens to see how we can try to mimic this as best we can. So for instance, and again, the purple lines here are your meal times. So let's say we're doing a combination of NPH plus regular insulin, okay? Again, this is not a common combination you see, but just to give you an example. Now, the regular insulin is going to be good for what type of correction? Fast-acting correction, slow correction? Fairly fast correction, right? So again, this is why you would end up taking around mealtime, right? So you take it one time in the morning, and then you take it around supper time as well, okay? You'd also, at the same time, be taking this NPH insulin, which has a much longer duration of action. It's going to be able to cover those basal requirements. And so you can see here, and this would be an example of a two injection regimen where basically you'd be giving regular and NPH at the same time. So they take one injection in the morning. NPH is going to cover them throughout lunchtime, hopefully, and then by the time they get to supper time, both the insulin should be out of the system essentially, and then you're going to redose, and then the NPH should be able to cover you throughout the night. Okay, that's one way to do it. And again, what do we say is the drawback of using just like a 2-time injection system? Twice daily injection. You get less tight control, right? Less chances for hypoglycemia probably, but you're going to find less tight control. You're probably going to find that they're going to be hyperglycemic somewhere throughout this period where kind of both of them are starting to run out, right? So maybe after their lunchtime readings, they'll check their glucose and it is coming up high, right? Here's an example. We're going to use an ultra lente form, which is a very long-acting form, and plus they're going to have regular insulin doses at mealtime. So this would probably be something that would be a 3-time injection regimen where they give themselves regular and ultra lente right at breakfast. Regular insulin effects. Take another injection at lunchtime, and then an injection right before supper time. Okay. Now notice, are they taking this with the meal? Are they taking it before the meal? What do you think? You're taking the insulin before the meal, right? Again, depending on the insulin, you're going to find that can range. So the really ultra short acting, like the glulisine, is actually the fastest acting one. They can actually take that with the first bite of their meal. Sometimes you need to take it 15, 30 minutes beforehand because you have to give it time to get absorbed from the subcutaneous tissue to get into the bloodstream to have its effects. Okay, so typically you need to know when you're going to be eating in order to make sure they go ahead and get that insulin on board, right? So that's one regimen they could do. And then here would be an example of an insulin pump. Notice here it's just one type of insulin, regular or short-acting insulin, and it's just going to see that it'll release its basal amount. Once you program in the carbohydrates you're getting for your breakfast, it'll then give a little bolus. Usually they'll try to mimic that kind of biphasic sort of peak that you see with normal insulin release from the pancreas. And again, that's going to be the closest to mimicking what the actual pancreas is doing. But again, what do you think are some drawbacks of using a continuous pump? Are the pumps perfect? Are all the machines we use perfect? No, we'd like them to be, but sometimes they have malfunctions. Maybe they're not working well. Maybe they stop releasing insulin. Maybe they give too much. I had one student many years ago who was, I was like, yeah, these pumps are usually pretty good. And she's like, no, I totally ended up in the hospital because my pump malfunctioned. And I was like really hyperglycemic and almost in DKA. And I was like, oh, wow. So these things actually absolutely do fail. Other things, if you have this catheter, this subcutaneous, sitting in there for many days, weeks potentially, what could you see happen? Infection, right, is a concern. You have to make sure you keep it clean. You have to think about things like showering and all that kind of stuff. So again, there are some concerns with this. It's not a perfect system, but one day we'll probably get to having some kind of implantable pancreas that can just automatically monitor it for you. And then when we have like robot modifications to our bodies, it'll be a much better day. My lectures will be obsolete. But again, that's kind of the closest thing we can get to mimicking the pancreas so far. Right? So looking at this, so looking at a regimen, looking at initial insulin doses here, how you would compare them between a type 1 diabetic to a type 2 diabetic patient. What do you think? How do you think these are comparing? Why do you think one requires a much higher dose? Type 2 diabetics are going to be much more insulin resistant, so you notice their initial daily dosing is going to be much higher than someone who's type 1 diabetes. Now, does that mean that a type 1 diabetic cannot develop insulin resistance? Well, they can, right? Their diet's totally crap, and they're eating really poorly, and they're just trying to supplement their insulin in order to deal with that extra glucose. Like, yeah, they're going to get resistant as well over time. But again, just looking at initial regimens, this is what you'd expect to see, right? Now, typically, how we're going to divide it up is you're going to find that 50% is going to be a basal amount or a long-acting form. So, for instance, I had the patient, and again, I'll give you an example here. I'll just talk about that in a second. But 50% is going to be your basal long-acting form. 50% is going to be your bolus, either regular or more often than not a rapid-acting insulin. And that 50% of that bolus dose gets divided up into how many ever times you're going to be giving that per day, which is frequently how often? Probably 3 times, right? So you usually eat 3 meals a day, so typically you're going to get three doses there. So as an example, if I had a 40-kilogram female who's diagnosed with type 1 diabetes, we're going to start her off by figuring out what her total insulin dose is going to be throughout the day. So we're going to say, let's do 0.5 times 40 kilograms, so she needs 20 units of insulin per day. Now again, can I just give 20 units of insulin glargine right at breakfast time and then call it a day? You could, but you're probably going to find that your postprandial glucose readings are going to be pretty high, so you're not really going to get that tight glycemic control. I'll talk about some exceptions to that where one-time daily injections might be more appropriate for like a type 2 diabetic patient, but for a type 1, let's not go with that. So we're going to say, okay, well, 50% of the basal rate should be 10 units, right? So we're going to say divide that up. So we're going to use insulin detamir subcutaneously twice a day. So we'll get 5 units in the morning and 5 units at nighttime. Conversely, you could just do 10 units in the morning, but it depends. Sometimes patients run high overnight, and so sometimes you want to give that as a nighttime dose. Just depends on the patient, right? But let's say we're going to do that twice a day. And then the other 50% is going to be bolus insulin, right? And so maybe we'll do 20% at breakfast, 15, and then 15% at lunch and dinner, right? Normally breakfast tends to have a little bit higher carbohydrate intake, right? The most important meal of the day. So we get a little extra carbs there. So we'll go ahead and give Lispro, insulin Lispro, which is how fast acting? Pretty fast acting, right? It's one of the ultra rapid acting insulins there. So we'll get 40 units with breakfast, we'll get 3 units with lunch, and then 3 with dinner there, okay? Now again, that's just a starting point. And how are you going to determine if I need to change the doses at all? You mean monitoring your sugars, right? And so again, very frequently you'll find that the point-of-care test will have like automatic recording functions, so that way when you bring it to your doctor's office, they can look at it and say, okay, well here's the past readings. Let's see. Okay, looks like you're always running high around lunchtime. Okay, let's talk about what are you eating at lunch. Blah blah blah. Maybe we need to bump it up. So maybe you're doing say 4 units at lunch now instead of 3. Right. So those are changes you're going to make based off how the patient's actually reporting it, based off what their glucose checks have been. Okay. Make sense so far? Pretty straightforward, but again, unless you've kind of seen it a few times, it may not make all the sense in the world. Actually, I had a patient yesterday. It's kind of a very interesting sort of regimen where it was a cystic fibrosis patient. She said, do they often get diabetic? They can, right? Because we talked about the exocrine function of the pancreas is blocked, right? Because they have all this thick secretions, right? So again, they found they kind of auto-digested the pancreas. So we had a type 1, basically a type 1 diabetic patient with CF. And so they actually were receiving, mealtime throughout the day, but the patient, what do we talk about the nutritional requirements for a CF patient? Yeah, they probably need, they have a hard time absorbing a lot of nutrients because again, they have, less fat absorption, things like that. And so, we're giving enzymes to try to help out with that. We talked about that for CF patients, but they really weren't getting enough. So what they were doing is at nighttime, they would actually get continuous enteral feeds. So a patient would be sleeping, but they're still getting to eat, so that way they get a little bit better coverage there. And so actually what they ended up being on is that they were on insulin Lispro, which is a short-acting form, 3 times a day with meals, which makes sense. And then actually at nighttime, they were on NPH insulin plus insulin glargine. So they're on an intermediate acting form plus a long acting form. Does that make a lot of therapeutic sense? It didn't to me either. So the problem though is that who was the one writing these orders? Well, as a patient being admitted to their CF patients, they're admitted to the pulmonology service. They have the pulmonologist, are the experts in endocrine stuff? No, right? So the pulmonologist is writing these orders, and they're basically writing, so continue home meds, right? So they're writing orders based off what the home medication list was. And I was like, hey, this looks really weird. Are you sure that, I just want to confirm that this is correct, because when I see that, I said, this looks like an error. Usually sometimes if the medical record will not say when a medication has been discontinued, so sometimes we'll just order stuff together not realizing they actually don't need it. And so yeah, I texted the doc and I was like, hey, what's up with this? She's like, well, I was just following Endo's note. And if you look at Endo, they certainly said actually do both of these, because again, the overnight feedings was not really a normal thing. And so we're like, okay, well, we're not really sure. This seems a little iffy. The dose wasn't until like 10 o'clock that night anyway, so we had some time to worry about it. She said, okay, well, I went ahead and put for an endo consult. We'll get the endo doc to come in, take a look at it, see if it actually is necessary, and if so, then they continue on with it. But again, if you're not sure, always make sure you're asking the questions, referring back out to whoever made those initial recommendations in the first place. Because the endo doc says, oh yeah, absolutely, this is what we need to do, and then I feel much better about it than if it's the pulmonologist being like, yeah, just do it. Right, so again, know who your experts are. Anyway, and again, make sure you're adjusting based on the individual patterns. Again, everyone's going to act a little differently depending on how they're responding to it, based off their diet, based off a million different factors. Again, they're all snowflakes, not in the derogatory sense, but again, they're just all a little bit different. Okay. Insulin pumps, as I mentioned, can provide that basal and bolus dosing of insulin throughout the day. And actually, this is the other case. I had a type 1 diabetic patient who was in the ICU for DKA. Right, which can happen even if they're compliant with their meds, they still end up in DKA. And actually, they were transitioning from the continuous infusion insulin IV. So if you have a DKA patient, you actually put them on IV insulin drip to try to get their blood sugar under control. And then they had to transition them back to their home regimens. And so we actually had one of the practitioners in the ICU, they were reordering their home meds, which included the insulin pump. As a patient, that 9-year-old was talking about, I went to go see to talk about their insulin pump. And the provider also had ordered for insulin glargine at nighttime. And so I said, well, wait a second, this patient's on a subcutaneous and continuous pump and also this long-acting form. That definitely doesn't make sense, right? Because the pump should be doing what? Should be providing the basal line of insulin. So I said, well, something's not right here. So I went ahead and contacted the provider, and they're like, oh shoot, I didn't realize that I was actually on that. I should have been discontinued because that was part of the patient's old regimen. So again, if something just doesn't look right, make sure you ask a question, because in that case, what would have happened if we had put the patient on both of those? Hypoglycemic, right? And again, that's at nighttime. No, yeah, wouldn't woke up, right? So maybe if the nurse hadn't come in the room, she's like, oh, whatever, that patient's chilling out, they've been sleeping all night, no big worries, right? Come in, patient dead in the morning, right? They're not on the monitor or something like that. So just something to consider, right? Anyway, so again, just know that the patients here, they have to really be with it. They have to have really good, pretty good control on their insulin regimen. So typically, you don't start a patient off of the subcutaneous pump. You move them onto that after they do well with a traditional injection format. And so then they have to have really good attention to detail, because again, this is not a replacement for their pancreas in the sense that the pancreas can detect insulin levels and glucose levels and determine when it needs to release that. Again, one day we may get there. But so far, we still need to make sure we're actually doing manual point-of-care testing. We need to make sure that we're doing, good checks on that. Make sure we're inputting our carbohydrates, appropriately. The insulin sensitivity factors are built into it. All of that to make sure they're getting the right doses there, right?
Can the pump be scheduled like per time, let's say? So at this time, give me a shot or whatever.
So why do you think that might not be a good option?
Well, the way I'm thinking is you could do a long acting if the pump did that, and you would just have to eat a specific time.
Mm-hmm.
Trick, having to eat a specific time.
Do you get to eat at the same time every day?
Well, not at PA school.
Not at PA school, right? Sometimes like, oh man, my cortisols are so high, I'm not going to eat at all because I have a stress ulcer now and it hurts when I eat. Right, so again, life can throw you some loops, right? So again, you could potentially maybe schedule that out, but typically what they do is it'll have to be something where they need to program it in. So if they skip a meal, they skip the insulin dose, right? They'll still have the basal going on, or if they have like a big snack or something, if they may move lunch or something, you want to have that flexibility there. Because otherwise, if it's pre-programmed in and the patient doesn't eat something and they're not able to get to that food, then that could be a problem, right? So typically, no, you don't reschedule it, or you don't kind of schedule it like that, but that is a thought. But it's not typically what we see, right? Anyway, and again, patients need a lot of extensive training. That's where diabetic educators are absolutely paramount to this process here. And again, pump malfunctions could lead to extremes in either way, right? It's either giving too much insulin, too little insulin, and so it's really that's why we see some patients get admitted to the hospital because of those pump malfunctions there. So it's something to consider. They're not perfect. I actually had one student several years ago who actually had a subcutaneous monitor for glucose that was put, I think it was like in the back of her arm, and actually communicated Bluetooth to her phone. It was actually kind of interesting. I was talking to her about it, and she said, it works pretty good most of the time, but actually the sub-Q glucose takes longer to equilibrate than you would if you're just getting a typical stick from the fingers. So it said sometimes, the reading would look normal, and then, base our insulin off of that, and then an hour later the glucose actually come back high because that finally had re-equilibrated. So some of the Bluetooth wouldn't work appropriately. So it's a new technology, and you'll see this get better as time goes on. And again, eventually they'll probably have something implantable that you'll just won't ever have to think about again, which would be awesome. But that's kind of where we're at this point. All right, so any questions from the first half? So Namita had a very good example. She was like, oh, my brother takes insulin. This is weird. He's on an insulin pump and on the inhaled insulin, the Afrezza. Why would you say that's stupid?
Why would you take, on a pump, right?
He's on a pump.
Why would, if you have a pump, what's the point?
What's the point? That's what I said. I said, what's going on? Now, again, I don't say that's stupid, right? So it's a very good lesson as well. Learn to be tactful in your interactions. If you don't understand why something is happening, it could be stupid. You don't necessarily want to lead on with that, right? You don't want to be like, well, why are you taking that? That's dumb. Like, no one's going to respond well to that. Normally, you got to go up and be like, hey, I noticed you were on this and this. What's up with that? Usually by taking a more curious sort of approach rather than judgmental, you typically get more flies with that particular brain of honey, I guess. To let my analogy run off the rails a little bit. But again, yeah, so go in with a curious sort of attitude saying, well, that's interesting. How come they decided to use both an insulin pump in the inhaled form? And so we actually asked him and we said, what's up with that? And actually, he's not actually taking those two together. But that's an important concept, right? Because if you go through someone's medical records and if you're looking at their medication list, so for instance, we use Epic at Nemours, and you might use Epic in a lot of hospitals you go work at. They basically have this medication list, and that's the home meds, and stuff will stay on there for years and years and years. And so you may look at that, and so you as a provider going through and you're ordering all their home meds, and you may order both of those together, and be like, what the heck? Why are they on both of these together? You may not realize that, well, they'd actually told him to discontinue the pump, and now he's taking a long-acting form in addition to the inhaled form, which makes more sense, right? So that way the inhaled form is a short-acting, that's going to be your mealtime insulin, and then you have a long-acting form for your basal amount. So thank you for letting me use that example. It's very good because, again, you can ask that question, what's up with that, right? The SNL skit, what's up with that? Yeah, anyway, go check it out. It's funny. So looking at hypoglycemia, we mentioned this is a big risk with using insulin. And again, you may have some patients who may develop this kind of unawareness of their own hypoglycemia. It's going to happen with things like autonomic neuropathies. If they have more frequent episodes, sometimes they kind of get a little bit blunted to the responses there. But typically we consider anything less than like 65, 60 to be considered hypoglycemic. Now again, when you get hangry, if you've ever been hangry before, what's your natural response? What do you want to do? You want to stab someone, but typically if you get access to food, what do? You eat a lot of food, you overcorrect, right? You go a Cookie Monster, and then you get hyperglycemic. So that's a frequent concern, right? So you feel hypoglycemic, you tend to overcorrect there. And again, we're leading to the opposite problem. So normally what you can do, and what a lot of these patients will be educated on, is a rule of 15. Basically what they'll do is they'll ingest 15 grams of simple carbohydrates. So let's say simple versus complex, what does that mean? Yeah, just straight sugar, right? Easy to break down carbohydrates, so we don't have to sit there and try to break apart with amylases and things like that. We want straight, simple sugar, so things like orange juice, things like milk, things like glucose tablets, which some of these patients will carry around with them, similar to like an EpiPen if you had anaphylaxis or something. You'll use 15 grams of carbohydrates. They will then wait 15 minutes, check the glucose again. If it's still less than 70, then they'll repeat that process, right? The idea is to kind of gradually bring the blood sugar back up above 70, rather than trying to overcorrect and all of a sudden they check it again and it's like 200, right? So that's not the goal, because then you have the opposite problem you have to deal with, and then you have to kind of work around that. So that's the general thing you're going to do. Well, that implies that your patient is still conscious, it implies they're still with it enough to take something orally. What do you do if they're unconscious? Or D50, what's D50? 50% dextrose, right? What else could I do? Glucagon, right? It's going to be the other option, right? So then if the patient is not able to take oral carbohydrates, we have to switch over and use parenteral formulations, right? So that's where we're going to get into things like our glucagon. Again, this is something that a lot of patients, especially new diagnoses, they're going to get a prescription for glucagon to go along with all their other stuff. Usually, you can always tell if you're working at a farm, which you guys will never work at a pharmacy, but presumably, unless you take some weird path in life. But I can always tell when I'm getting a new diagnosis diabetic, because when they come in, they usually have about 40 different prescriptions of all the insulin they're on, all the pens, all the needles, the test strips, the glucose monitor, everything else, and they usually will have a prescription for glucagon, right? So again, this is meant to be used if they become hypoglycemic. Usually this is going to be something that someone else is going to give to them if they are unconscious or they're not able to administer it themselves. But it's good to have around because it can be a good emergency, short-acting sort of thing to fix those glucose levels. So basically we're giving glucagon. It's a synthetic hormone, basically what we normally will produce, and we'll use this to help stimulate glycogenolysis and gluconeogenesis in the liver. So for glucagon to work, you have to have what? Yes, you should have a liver. Let's presume that most of our patients have livers. You have to have the storage, right? You have to have the glycogen stores in order to make that work. So sometimes what you'll find is that patients who've been hypoglycemic for a long period of time, they may not have those glycogen stores, right? They may be malnourished, they won't have those stores, and so you use glucagon, and you really won't see that appreciable rise in glucose. So in that case, it may be somewhat limited. For most patients, though, it does tend to work pretty well, though. And this is going to be an intramuscular injection you're going to be administering. We can use it IV in the hospital setting, but we'll use it intramuscular on the outpatient setting. And again, this is something where it actually comes as a dry powder. And again, why do we have some drugs? Why do they exist as a dry powder? It helps with the stability. Yeah, if you take all the moisture out of it, it tends to stay stable for a lot longer. Does anyone know what that process is called? Where you freeze dry a powder or a liquid? Lyophilization, yeah. So this is a lyophilized powder essentially. So again, nothing you're never going to need to know, but it's good trivia. It's a lyophilized powder that if you see the syringe here, it actually has the liquid in it, the diluent. You'll then inject that into the vial. It'll reconstitute, right? Now again, anytime you have proteins, this is a good rule of thumb for proteins, you don't want to shake them up because what happens? They'll get frothy, and that froth is basically all the proteins coming out of solution. You don't want that, right? You want things to stay in solution. So anytime you're dealing with a protein-based product, this includes insulin, this includes a glucagon. You want to make sure you don't shake it up. You kind of, if you need to warm it up, roll it in your hand. You can kind of gently swirl it, but that's generally the best rule of thumb whenever you're trying to reconstitute this stuff. To reconstitute it, pull it back out, and then inject it intramuscularly, right? So that's going to be the best way they can get that glucagon in the system very, very quickly there. Some other effects, some other places you might see glucagon being used, is it actually works as a stimulant on the GI tract to some degree. It actually works to relax some of the smooth muscle in the GI tract. Sometimes, especially when you have like say a foreign body ingestion in a child, they come in, say for instance they swallowed a quarter or something, and it's sitting there in the esophagus. You get the KUB and you see exactly where it's at in the esophagus. And say for instance like 11 o'clock at night on Saturday, and the GI doc doesn't want to come in to scope the patient. Sometimes they'll say, well, give them a dose of glucagon. By trying to loosen up that esophageal muscle, they can try to get it to pass, and then once it's in the stomach, then you don't have to worry about it so much. Then it can just kind of pass on its own throughout the rest of the GI tract. So sometimes you'll see that for foreign body ingestions. We'll use it for that. But also because it's loosening up all that esophageal muscle, what else do you think could be a common side effect? You have reflux of stuff coming up, and you get nausea, vomiting along with that. So a lot of patients will get very nauseous whenever they receive glucagon, and so it's important to make sure we try to pre-medicate with Zofran if possible. So we'll oftentimes give those two together.
Why is glucagon used as a beta blocker with calcium channel blocker?
That's a great question. I could probably give a whole hour-long seminar on why we give glucagon for beta blocker, calcium channel blocker injections. Basically, a shortened form is that when you have a beta blocker, say for instance a beta blocker overdose, how do you think that presents? What sort of cardiovascular manifestations would you see? Bradycardia and hypotension, right? So basically by blocking all those beta receptors, I could release a ton of norepinephrine, epinephrine, I can give them exogenous epinephrine, wouldn't really do anything because all those beta receptors are blocking the heart, right? So what I can do with glucagon is it basically will kind of stimulate kind of a backdoor pathway to increase cyclic AMP in the heart, to actually increase utilization of glucose, will increase contractility, will increase chronotropy to get the heart rate back up, will increase cardiac output, and the blood pressure will come back up. So again, don't worry about it for this test, but that is oftentimes why we'll see that. Again, I can give a whole hour-long lecture on why that is, but anyway, so again, a couple of different uses for glucagon you may see out there. Again, usually I don't see it work too well for the foreign body thing, but sometimes I'll recommend it just so that way they may not have to scope the patient. Does anyone know anything more concerning about like if you had like a quarter ingestion? Any other special concerns? Most of the time it's going to be fine as long as it passes the esophagus, but if it does come out as 2 dimes and a nickel, then you got a problem, right? Toxicology jokes, right? Anyway. So if we have, say, glucagon is not working, or say we need to give something else, this is where IV dextrose is going to be coming into play here, right? So again, this is typically by the time EMS responds, when this is going to be administered here. So we have a couple different concentrations. There's D10, D25, and D50. Again, that all goes to the concentration of dextrose. So dextrose 10, D10 is 10% dextrose, right? You guys remember what I said about percentages, how you figure out the actual milligram per ml concentration? Just 1 over, right? You just move the decimal place 1 over to the right and you'll get the new concentration. So for instance, with D10, it's 100 milligrams per ml of dextrose. That's important when you're trying to figure out what dose you're going to give, especially to like a child, because normally the dose is going to be between 0.5 and 1 gram per kilogram, okay? Usually that equals out to about 25 grams for adult patients, right? So and that makes sense based off the fact that usually D50, which is 500 milligrams per ml, usually comes in a 50 ml syringe, and that's usually what you'll find in crash carts and things like that. If you slam that IV, that's generally 25 grams of glucose to try to correct that patient, right? And what do we say about the rule of 15? How much were we administering orally? 15 grams, so we're giving 25, we're giving a bigger dose, but hopefully they're probably because they're more hypoglycemic, right? So again, we're trying to get them corrected there. Just be aware that when you're using higher concentrations of that dextrose, it can be very irritating to the veins. So usually for very small kids, especially like neonates or something, we're going to stick with like D10. For a little older kids, maybe D25, and D50 is going to be more relegated to the adults, right? You can always dilute it if you needed to, but that's generally what we're going to be shooting for. Most little kids are going to give a D10 for the most part. Now, using a less concentrated form means you have to give more what? So if it's less concentrated, when I want to give the same dose, I'm going to need more volume, right? So again, you have to think about the amount of fluid you're actually giving to that patient as well. So if they're fluid restricted, you may want to use something that's going to be more concentrated, right? So these are little things to consider there. Yeah. All right. So looking at your treatment goals, again, it can depend on the organization you're looking at, but generally they're shooting for things like getting the A1C under control, either less than 7 or 6.5. They're looking at preprandial and postprandial glucose levels to see if make sure those are under control. And again, as we move into out of the insulin talk and into more of the other diabetic medications, you're going to find this is mainly what we're shooting for, right? So again, we're going to find that either our medications are looking to get more insulin active, or we're going to try to find that a lot of our medications are going to try to sensitize the body to the insulin that they may be already producing. Okay, but again, these are mainly the goals we're going to be shooting for. And again, depends on the patient, depends on which organization you're following, etc. So, looking at type 2 diabetes, typically you're going to have the diagnosis. And again, do we diagnose a type 2 diabetic patient, usually pretty quick as soon as they become diabetic? Not usually. Usually it's been going on for a very long time. There's usually a lot of lifestyle choices that have led up to that decision or led up to that diagnosis there, and so you're going to find that usually they've already lost a significant amount of pancreatic function, or they've developed a lot of insulin resistance, as the case may be, right? So usually we're kind of behind the 8 ball for some of these patients, especially depending on how delayed they are in diagnosis. Ideally, we're going to initiate lifestyle changes, which includes what? Diet's a big one. Exercise is a big one. Anything else? Those are the 2 big ones, right? Diet and exercise. Does that work for the majority of patients? No, because diet and exercise are what? They're hard, right? So we don't like to do hard things. However, if I can take a pill, that's really easy. I can do that, no problem. So that's usually we're going to start off with monotherapy for these medications, anti-diabetic medications. Then we'll move on. Patients who are not adequately controlled just with lifestyle modifications and monotherapy, we'll move on to combination oral therapy. And then generally we'll move on to combination therapy, usually including insulin at a point. Okay, so again, you're going to find that most of your type 2 diabetic patients will start off on oral meds and they'll eventually move on to insulin, depending on how well or not well controlled they are, as the case may be, or just how progressive they get. As they get older, more likely to get moved over to insulin. So looking at this, you see that the insulin resistance these patients are developing, it can be pretty dramatic, and not only just in their glucose levels, but also looking at things like glucagon levels, looking at things like other hormones like glucagon, like peptide 1 or GLP-1. Those can all be markedly different in diabetic patients. So this one's looking at glucose and insulin response in patients with, say, normal glucose tolerance, like in the blue line here, people with impaired glucose tolerance, so not fully type 2 diabetic yet, and then someone with type 2 diabetes. And so what you notice here with the plasma glucose, obviously type 2 diabetics can be higher, right? But also looking at the plasma insulin levels, and say this is going to be in relation to a mealtime bolus or some sort of bolus of insulin here, or a bolus of carbohydrates, I should say. What do you kind of notice about the insulin levels in, say, a normal patient versus someone with type 2 diabetes? Well, what you're going to notice is that for the patient with normal glucose tolerance, as they have that spike in dextrose, or that spike in their blood sugar, you can see that, yeah, it'll peak up a little bit, but then it goes back down to relatively normal levels here. And you'll look at their insulin concentration, see it spikes up, and then it goes back down to normal basal levels. Okay, This one has normal response to insulin. What you notice about patients with impaired glucose tolerance, now they've developed some insulin resistance, you notice here that the insulin levels are going to be higher for longer because it's having to work harder to try to get that glucose levels back down. Okay, so we're seeing that even though they're producing insulin, they're not really responding that well to it, and that's why you're going to have much higher insulin levels around for a longer period of time. And then what do you notice about the type 2 diabetic patients? Overall, their insulin secretion is what? It's lower than someone with the impaired glucose tolerance, right? Because again, they've already kind of worn out the pancreas to a point where they can't even release as much insulin as someone with impaired glucose tolerance, and they're going to stay again that kind of high peak, kind of high plateau effect for longer because again, their blood sugar is going to be chronically high. Make sense so far? So again, it's not only an issue of insulin resistance, but also the fact that they're not going to be able to release as much insulin as they get more progressive. Okay. Looking at glucagon levels as well. So again, here at time 0 is where they get a kind of a bolus of carbohydrates. You're going to find that for someone with normal glucose tolerance, again, they get that big spike of insulin and it goes back down. For someone with type 2 diabetes, they don't really get that same spike because they're just not able to release as much. But also as interesting is the effect of glucagon. Normally, if you have a bolus of carbohydrates, you expect glucagon levels to do what? Go up or down? Well, if insulin goes up when I eat that fried donut I mentioned earlier, that some of you may have been thinking about this whole time. You shouldn't have insulin levels go up. Glucagon levels should do what? Should go down, right? Because again, blood sugar is high. Glucagon is not needed at that point, right? The body doesn't need glucagon to raise up those blood sugar levels because they're already high. So what you notice in someone with normal glucose tolerance is that you're going to find that the glucagon levels should go down, right? It should start to plummet as soon as you have that increase in blood sugar, right? Increase in insulin is going to cause that decrease in glucagon. What do you notice in the type 2 diabetic patients? It stays high, right? What does that do to your blood sugar? Makes it even higher, right? So again, you can see it's kind of a compounding sort of effect here. So again, they're not releasing as much insulin. They got too much glucagon. Their cells aren't responsive to the insulin, so it's a multifactorial sort of issue here. And we're going to find there are medications maybe focusing on different aspects of this in order to try to get things back to normal for these patients, right? So here are the different classes of medications we have for our type 2 diabetic patients. We're going to have drugs that stimulate the pancreas to make more insulin. So these are include our sulfonylureas and our meglitinides. We're going to have drugs that sensitize the body to insulin, or they help to decrease the amount of hepatic glucose production. So they're going to help to stop glycogenolysis and gluconeogenesis. That's going to include our thiazolidinediones, otherwise known as TZDs. And we're also going to have our biguanides. Anyone know what falls into the biguanide category? Metformin is going to be the big one, right? So metformin we're going to see is going to be our go-to kind of first-line diabetic medication for these patients. We're going to have drugs that help to slow the absorption of starches. These are going to be our alpha glucosidase inhibitors. And we're going to have some meds that will suppress glucagon, they'll decrease gastric emptying and decrease food intake. So these are incretins, or glucagon-like peptides. And then you're going to have some drugs that will decrease the reabsorption of glucose from the renal tubules. So we get our SLGT2 inhibitors. Okay. So again, we have a lot of different ways to target this. Why do you think we have so many different classes of drugs? Like, why do we have to come up with all these? Well, because one might not be enough for some of these patients, right? Depending on what the issue is with them, whether it's glucagon, the insulin, the resistance, etc. But also, like, this leads to so many different complications, right? The macrovascular, the microvascular complications. We know that this can lead to death in a lot of cases, so we need something to really try to get this under control. So you'll find that a lot of these patients are going to be managed with multiple medications to try to get that under control because we know that's going to help to prolong survival, right? So just, and again, looking at the effects of some of these different meds on glucose levels and A1C concentrations just on monotherapy by itself, you can see here the relative effectiveness of these different medications here. And again, something that increases insulin secretion, like, yeah, it's going to be pretty good at helping to decrease that fasting plasma glucose levels, right? It's going to help decrease that A1C pretty well. And is there going to be some synergism when you add these together? 100%, right? So you're going to see that by combining different classes together, you get more effects than just one of them by themselves. So that's why a lot of patients will start out with monotherapy. Eventually, they're going to need combination therapy, which again can be a problem from a compliance standpoint, but that's why we have a lot of combo meds that are available out there. Okay. All right. So starting out with our sulfonylureas, these are oral hypoglycemics. So just off that bat, right, just knowing that they help to increase insulin release, what do you think is going to be a main side effect from these drugs? They increase insulin release, so you're going to expect to see hypoglycemia, right? Hypoglycemia is a main side effect from one of these, right? In addition to that, what else can they cause? More insulin means more, what does it do to your weight? Weight gain, right? A lot of these type 2 diabetic patients are underweight, normal weight, overweight. A lot of these are overweight patients, right? So again, think about what their patient's weight starting out is, what effect the medication is going to have on that. We're going to find some of these are going to be very potent in causing weight gain. Some of these are going to have more neutral effects. Some of these will actually cause weight loss, which can be a really big benefit to some patients, right? So again, let's look at, we'll kind of go through those and talk about all of them. There's a nice table at the end of this lecture that kind of goes through and compares all of those and talks about the different pros and cons of all the different medication classes here and why you might choose one drug versus another for these patients. So anyway, we don't really use too many of the first generation agents anymore. Certainly the second generation ones we do use, and this includes your glimepiride, glipizide, and glyburide. Okay, a lot of these come as, say for instance, like an XL formulation. Again, the benefit of that is what? You get long-lasting effects throughout the day, so you typically have to give it how often? I'm sorry. One time a day, right? So it helps from a compliance standpoint. The Glucotrol XL is kind of interesting because it comes as a little tablet and it actually has a tiny hole right in the middle of it. And so basically what happens is via osmotic pressure within the GI tract, it will draw water into the tablet that will expel drug out of the hole. And then eventually the patients will then see that tablet actually can come out in the stool. So if they see that, it's one of those things where like, oh, wait a second, did the drug even work? It's like, yeah, it did. It's not meant to be, it doesn't dissolve like a normal tablet would, and they'll see it come out at the end there. But it definitely did work based off the actual mechanism of it. So again, weird dosage forms you may see out there. But these are essentially working to block those potassium channels. Remember back when we were talking about the insulin release caused by blocking those potassium channels. So potassium efflux is decreased. So we're going to see the cell hyperpolarized or depolarized. More potassium in the cell leads to depolarization, right? Because it's more positive on the inside. So it leads to a depolarization that leads to those voltage-gated calcium channels to open up. Calcium flows in or out into the cell, and that calcium causes degranulation of those vesicles, okay? So again, by blocking these potassium channels, it's going to cause calcium channels to open up. See that right here? And it's going to cause the vesicles to release the insulin out. Now notice this is independent of the glucose coming in, because normally what would happen is that glucose got turned into ATP, and that's what triggered this whole cascade to occur. Versus the sulfonylureas, they can do it directly because they're going to be blocking those potassium channels directly, causing the degranulation. So again, these can be very potent hypoglycemic agents, especially if the patient's hypoglycemic to begin with, right? So again, this is one of those drugs that are potentially deadly, especially if like a toddler gets into this. This is one of the big ones I really worry about when I hear about an accidental ingestion, or if I hear an intentional ingestion, I took a whole bunch of this stuff. This is one of the more dangerous ones because they become profoundly hypoglycemic, very difficult to deal with getting their blood sugar back up. And again, a lot of them are XL formulations. They're going to be sticking around for quite some time. But anyway, so this is how they're going to be working. Very potent at getting the blood sugar down, but again, you're going to see weight gain. You're going to see a lot of hypoglycemia associated with these as well. And again, think about the age of your patient. The older they get, the more likely they are to see those hypoglycemic effects. Again, they have a lot less hemodynamic or homeostatic reserve than, say, a younger patient might. Okay. Again, here it should cause insulin receptor sensitivity to go up, insulin receptor number to go up. In these cases, here's kind of another kind of bystander sort of effect, and glucagon level should go down based on the increase in the insulin release there. Okay. So anyway, so again, a lot of them will have active metabolites, which again extend the duration of action, which again might not be great for older patients there as well. And so be very careful if you have patients with renal or hepatic insufficiency, because they tend to have the effect last for longer. If you remember, how do we clear insulin from the body? Say again? And so we release it from the urine. So remember, if you have renal dysfunction, you do hold on to insulin for longer. So again, this is natural insulin we're releasing there. If they have renal dysfunction, they may get hypoglycemic because they're not clearing the drug as well, or because the actual insulin they're producing is not getting excreted as well either. So again, it could be multiple reasons for that. But and again, note that we're not going to be using this for pregnant patients. It can actually deplete insulin from the fetal pancreas, which is no good. Could lead to some pretty deleterious side effects there. So again, insulin is always going to be the drug of choice for those pregnant patients with gestational diabetes. And again, looking at these, chlorpropamide is a first generation agent, had a very long half-life, long acting 48 hours or so. Saw a lot of hypoglycemic events in these elderly patients. You have to be really careful with these drugs with them. This one also causes a disulfiram reaction, which is what? A lot of flushing, nausea, vomiting, sweating in response to ingestion of alcohol, right? So again, it's only a combination of alcohol. And you're going to find chlorpropamide and glyburide tend to be the ones most likely to cause hypoglycemia just because they have kind of the most profound effects, longest half-life, etc. So And again, these are good for helping to get the A1C down. They're going to get the fasting plasma glucose levels down. You're going to see that these are going to be helping to increase insulin release all the way throughout around the clock. You can see it's going to be a little different when we talk about a different class, and here we get to the meglitinides. But again, very good for helping to get that rapid glucose control. But again, the tighter glucose control you get, the more likely you are to overshoot it and cause hypoglycemia. Glyburide, again, very common there. This also often comes in as these extended release formulations as well, so we don't have to give it one time a day. Again, that helps to increase compliance. Glipizide, another very common one. This is probably the most common one I run into for diabetic patients. Is going to be glipizide there. This one has a shorter half-life, so you get less hypoglycemia, so it could be a benefit for, say, older patients. Again, hypoglycemia, weight gain. I can see some other kind of miscellaneous sort of side effects, some constipation, nausea, vomiting potentially. But those are the biggest things, right? These are the things that are almost guaranteed to happen, right? So you gotta be really careful with that. Make sure they're aware of what the signs and symptoms of hypoglycemia are. You know, think about other comorbid conditions they have. If they have a history of, say, a heart attack, angina, they might be on what drug? What class of drugs might they be on that might interact with this? Like beta blockers, right? They could be on a beta blocker. So it could mask with signs of hypoglycemia, right? So they could become hypoglycemic, they don't know it, and get into trouble. Again, education is really important here. Now again, you see resistance may develop over time. Why do you think that could be the case? We said the pancreas of these patients is usually working overdrive anyway, so now we're stimulating even further. Again, that's going to help it to wear out even faster, right? So it's one of those things where we may see very good effects early on, but you may see it kind of peter out as time goes on, say in the next coming decade or so, and you're going to find that they will develop that resistance because they just don't have a ton of insulin release on their own, okay? So again, that may be the cue when you need to switch a patient over to exogenous insulin rather than trying to rely on their own pancreas to produce that. Again, you would not want to use this in type 1 diabetic patients. Why do you think that is? I can give it to them, but are they going to be able to produce a whole lot of insulin? No, not really. So again, it's not really going to be all that effective, so that would be contraindicated for them. Again, you would not want to use this in patient with diabetic ketoacidosis. The main treatment for that's going to be what? Insulin, right? You got to give them exogenous insulin, usually regular insulin, IV, most typically. You just be aware of the disulfiram reaction, protein binding interactions, which may increase the effect of the drug, so just be aware of those things. Up next, we have our meglitinides. These are going to work similar to the sulfonylureas. However, they have one distinct difference between them. And so the two fit in this category include repaglinide and nitegelinide. It's going to be Prain and Starlix. Now, I can tell you, I've probably never seen a patient actually on these. They're used exceedingly rarely. But basically what they're going to do is that they will help to stimulate insulin release, very similar to the sulfonylureas, but the main difference is they only do that in the presence of glucose. So the higher levels of glucose are, the more likely they are to stimulate the insulin release, which means when do you think they work best? Around meal times. So overall, they're not going to be as effective as the sulfonylureas because they're not going to be as potent at increasing insulin release. And they're only going to work really around that mealtime kind of postprandial kind of bolus of blood sugar. Okay. And so overall, they're less effective. You need to take them around mealtime, again, before meal times. If you skip a meal, probably should skip a dose, right? Because again, the drug's not going to be that effective. Not really going to get a whole lot of bang for your buck from that standpoint there. These are never used as monotherapy. Maybe added on to something else like a metformin, but for the most part, you're going to find these are not used all that too often. We just mention it so that way you're at least familiar with it if you ever see a patient come across on one of these. But that's the big difference, is that the sulfonylureas work kind of around the clock, regardless of glucose levels. These only work with really heightened glucose levels. Okay. So again, which one do you think has a higher risk of hypoglycemia? These are the sulfonylureas. Sulfonylureas, right? Because again, they're working regardless of glucose levels. So if I give someone who has a blood sugar of 50, a sulfonylurea, it's going to drop it down even lower, right? Versus if I give them Prandin or something like that, you may not see no difference whatsoever, or very modest differences. Okay. Again, very similar adverse effects. So what you see, the sulfonylurea is just going to be lessened for the most part. Okay. This is a big group. We have the biguanides. It looks like a big group. We actually only have like one drug we're going to be using out of this category here, and this is going to be metformin. I mentioned it though because this is kind of your gold standard, like first line drug you're going to be putting your type 2 diabetic patients on. And so they has several different mechanisms we're going to run into, and all of them are very good for helping to allow the patient to make better use of their own insulin. Right? We're going to call this an insulin sensitizer. based on several different actions we're going to see. There was a buformin. This was used in Europe, but it can lead to fatal lactic acidosis. We don't really use that anymore, but metformin, actually fenformin as well was removed, but metformin is the big one we use here. Okay, so glucophage XL, so you're going to find it by itself, and then you'll frequently find it in combination with some other drugs here. So for instance, metformin plus glyburide, you get better synergy there because now you have sulfonylurea increasing insulin release, and then the metformin is going to help you to use that insulin more effectively. So again, a lot of this will make sense from a synergistic if you consider the different mechanisms. Okay, so what metformin is going to do for us, one, it's going to help to decrease hepatic glucose production. So the liver itself is making less glucose. That means blood sugar should go down, right? It's a major source of our blood glucose is coming from the liver. It should help with peripheral glucose uptake and utilization, which means that the insulin sensitivity should go up, which we mentioned is a big problem for a lot of these type 2 diabetic patients. It's also going to decrease glucose absorption from the GI tract. So where they are intaking, you're going to find less of it getting absorbed. And also the big benefit here is that because it doesn't actually stimulate insulin release, there's little to no hypoglycemia. Okay, so that's why we like it as a first-line agent, because you're really not going to find a whole lot of weight gain with it. If anything, you might find a little bit of weight loss with it, and relatively no hypoglycemia. Okay, big benefit. It's good as a first-line drug for these patients because it doesn't cause usually the least amount of kind of impact on their lifestyle and whatnot. Versus a sulfonylurea, you do have to worry about that risk for hypoglycemia. Okay. So, although this is not metabolized in the liver, you're going to find that hepatic disease is still a contraindication for metformin, mainly because if you're not able to clear metformin, and it's normally clear renally, you can find that this will produce a lot of lactic acid. Lactic acid normally gets cleared in the liver. If you cannot clear that, then you can develop this lactic acidosis. And this is really the biggest sort of dangerous thing you can see with metformin is this fatal lactic acidosis that can develop. It's very rare. I'll tell you about some particular patients you want to avoid metformin in, so that way you don't cause this to occur here. Anyway, it's going to be excreted unchanged via the kidneys. But if you have renal impairment, you do not want to give metformin. Because if you can't clear the metformin, this is when you develop the lactic acidosis. Okay. And again, we mentioned it could be good for obese patients, especially because it's not going to cause really any weight gain. Might cause a little bit of weight loss for those patients, which is nice. And again, you're going to find relatively minimal hypoglycemia. So adverse effects, this is really rough on the stomach. And again, depending on the patient, you can drive the doses up pretty high here, but it's usually limited by how much GI effects you're going to get from this. So either we'll use, maybe we'll divide it up, maybe giving it twice a day to help mitigate that, or by giving a long-acting form. So if you see like glucophage XL, it's maybe just give them one time a day, and that way you get a little bit slower release of the drug. If you see a lot of constipation, diarrhea, heartburn, all of that, it can be really rough on the stomach. As I mentioned, lactic acidosis, potentially fatal. I've seen one case of a lady dying from this. Again, it was through no fault of her own. It was no intentional ingestion. It was just the fact that no one went through and checked her renal function, took a dive, started building levels of metformin, and all of a sudden developed this lactic acidosis, right? So it can happen. There's plenty of case reports out there, so you gotta be really careful. So you're gonna find this is gonna be more prominent in renal impairment. You're gonna find it in the elderly. You're gonna be more likely to develop this, and then also after surgery. What do you think after surgery? So after surgery might be a little bit more on the side of a little bit of an acidosis itself. You may be a little bit volume depleted. You may find patients maybe having a hard time kind of getting back to baseline as far from like a renal issue, a renal standpoint. So you will find that most times patients will be discontinuing metformin, say several days prior to surgery, in order to make sure they don't have any kind of interactions here. Okay. Should be aware of that. Also, you know, in cases, if you guys ever heard of contrast-induced nephropathy, it's an issue you can find sometimes contrast-related dyes in patients, like say in ER or somewhere that they need to have a CT scan with contrast. That can actually cause a precipitous decrease in renal function. If you were to mix this with someone who had metformin on board, you could definitely see this lactic acidosis develop. So a lot of times, if they're getting, like say, for instance, an elective scan or something like that, where they have a few days foreknowledge about it, they can actually DC the metformin beforehand, go a couple of days without it, clear it out of the body, and then get their scan done. So you can be really careful with renal function. This is not good for dialysis patients. It's not good for any patients with impaired renal function. Okay. Also, you can see megaloblastic anemia, and due to causing a decrease in B12 absorption. Right. So not just glucose, but also B12 can be affected here. So as I mentioned, contraindications, we used to base it off of serum creatinine. So if you ever see that, a creatinine above, say, 1.3 or 1.4, used to be the old recommendations, but definitely if their GFR is less than 30, I'm not going to recommend it for these guys. Okay, what's a normal GFR? 125, like 100, 125, somewhere around there. So again, this is pretty decent decrease in renal function by the time you get to this point. So just be aware that it should not be in this case, this would definitely be an absolute contraindication here. If they already have any existing metabolic acidosis or hypoxia, anything predisposing them to acidosis is going to worsen that. Hepatic disease, anything blocking it from being excreted in the kidneys, if anything kind of competing for those transport proteins, anything like that. And as I mentioned, should be stopped before surgery, okay? Because again, you can see an increase in lactic acid due to the impacts of surgery on those patients. And again, maybe not so much with something laparoscopic, but definitely more invasive surgeries. You're going to find that they tend to have increase in lactic acid. More acidotic, it can be worsened with this metformin. Okay. Because again, ultimately, what would you do with that kind of patient? So say you're admitting them, you took them off their metformin, you know their glucose is going to do what? So they're well controlled in metformin. You have to take them off of it for surgery. So glucose is going to go up or down? Probably going to go up, right? How do you manage that? You can do insulin, right? So a lot of times you'll find these patients will get put on a sliding scale insulin regimen once they go into the hospital, right? So because again, it's easy to manage insulin, especially in the hospital setting, because we can closely monitor them. So it's okay to DC this, switch them over to insulin in the hospital, and then put them back on their metformin outside of the hospital, right? So again, it all depends on their glucose levels and all that, but that's a very frequent thing you might see. Okay. So then moving on to the TZDs, the thiazolidinediones. These are also oral agents we have here. Everything's been oral so far we've been talking about, besides the insulins. These are going to include pioglitazone, rosiglitazone, and then troglitazone. This last one got removed due to liver toxicity. And then you're also going to find there's some issues with rosiglitazone. I'll mention in a second here. But basically what these are doing, these are going to be an agonist for this peroxisome proliferator activated receptor gamma, or PPAR protein. Okay. What this does, it actually helps to regulate some of the transcription in the actual nucleus of the cell to change insulin responsive genes. So by doing this, you're going to increase your insulin sensitivity. So that way, whatever insulin you're producing is going to be a little bit more effective than it would be by itself. Okay. So again, making the patient more sensitive to the insulin. So again, now we've talked about metformin. Now we have the TZDs that are both good insulin sensitizers. Now, do you think this would work synergistically with metformin? Probably, right? And you'll see combination pills that will put the two together. Because if you think about metformin, it's working on the liver, working the GI tract, working on the cells as well. But this would work synergistically with the TZDs because these are actually working on the actual cells themselves to make them more sensitive to that insulin. Okay. So again, what you're going to find, you're going to have pretty good increases in peripheral glucose uptake and utilization. So the glucose in the blood is going to get taken up by the cells to get used there. You're going to find this also helps decrease some hepatic insulin production, right? So via a different mechanism than what you see with the metformin. Again, this is not going to be a very quick fix. It may take 6 to 12 weeks to see kind of ultimate effects because, again, they're going to be slower because they're working on transcription, right? It's not a quick fix like you would see with like insulin that can work instantly, essentially. So patients you would not want to use the TZDs in would be patients with CHF. This tends to cause increase in blood volume, can increase edema, could be worsening left ventricular function for those patients. So do be very careful with those patients there. Again, you also want to monitor liver function as well. One of them got removed for liver dysfunction. We know the other two can have a tendency to cause increase in the LFTs. So if we start to see AST, LT start to get above normal, 3 times usually above normal, we'll go ahead and probably take the patient off of that, right? Just because even though the drug may be effective, we do see this causing some damage to the liver. It's just not worth it at that point. You'll see a little bit of weight gain with this, but not as much as you would see with the sulfonylureas. But that makes sense because, again, all that glucose is going where? It's going into the cells, right? So again, you're going to see a little bit of weight gain, but not as much as you would see with the sulfonylureas. And again, actually, rosiglitazone came under a lot of fire, and you may, if you've watched like daytime television, you might actually find some commercials on there talking about, have you been taking Avandia? You can get a big settlement for this because it gives people heart attacks. And so this is one of those things where I actually found that rosiglitazone was linked to some increase in cardiac mortality. And so because of that, it's still on the market, but it's not really used very, very frequently. Definitely pioglitazone is still used occasionally, but if you have a patient with any kind of high-risk cardiac history, I would probably just avoid the TZDs altogether. Probably just not worth it. We have better drugs that they can use other than just these. Okay. Up next, we have the alpha glucosidase inhibitors. So what do you think these are going to do? So these are not necessarily sensitizing the patient to insulin. These are not working to increase insulin release. These are actually blocking uptake of glucose from the GI tract. So by blocking the enzyme alpha glucosidase, you can't break down those more complex carbohydrates, and then they just stay in the GI tract and eventually get eliminated in the feces. So what do you think happens to all those carbohydrates stuck there in the GI tract? Yeah, so all those bacteria and whatnot living in the GI tract, they're going to start to, they say, wow, look at all this extra sugar we got around here, and they're going to start to chow down on it and turn it into gas, right? So what do you think are some main side effects from this? Bloating, abdominal pain, flatulence, absolutely. So from a patient compliance standpoint, this isn't really that great, right? Especially to have a big carbohydrate meal coming in, you're blocking all that reabsorption of the glucose there. It's all going to stay there in the GI tract. You're basically going to start to ferment all that stuff into CO2 basically, and it's going to be very uncomfortable for the patient, right? Has anyone ever had those sugar-free gummy bears back in the day? Don't ever eat them. They kind of do the same thing. A lot of those sugar-free products, candies and things like that, are actually sugar alcohols. They kind of do the same thing where they don't get absorbed to the GI tract, but they tend to get broken down by the bacteria and turn into a lot of gas. So again, because of that, it's not great from a patient compliance standpoint. They usually just feel miserable when they're on it. But the two in here include acarbose and the miglatol. Now, do you think these would cause hypoglycemia? Probably not, right? Because again, all it is blocking absorption of glucose. Doesn't really do anything to the actual plasma glucose itself necessarily. It kind of blunts the increase you would see with a high carbohydrate meal, right? And again, when do you think you'd want to take these? Probably with meals, right? That's when all that carbohydrates are going to be coming in, right? So anyways, those are big things to consider with these. The nice thing here is also that they're not absorbed. So who might this also be good to use in? Pregnant patients, right? So this could be an alternative to insulin if you didn't want to have someone actually have that drug absorption or any kind of systemic exposure. Could be used, again, not used too commonly for pregnant patients because, again, what are they having already? They're having a lot of GI complications as well, right? They're constipated, they have hemorrhoids, or nausea, vomiting. Do you think you want to add this on top of it? No, that should be even more miserable. So you don't see it used too frequently. Again, diet, maybe insulin is going to be best for those patients there, but something to consider. And typically you'll take it with the first bite of each meal, so that way it's going to be able to help block that glucose from being absorbed in the first place. Okay. Typically these will not be used as monotherapy. Really, the only thing we've seen so far that could be used as monotherapy would be either the sulfonylureas or metformin. Usually metformin more frequently than not, but these are good adjunctive agents. If you need to add it on to something like insulin or add it on to another oral agent, that'd be a good, okay combination. As we mentioned, a lot of abdominal pain, a lot of diarrhea, and a lot of flatulence, right? So all the undigested carbohydrates get turned into CO2 by the bacteria. It's got to come out somewhere, right? And so we would not want to use this in patients with inflammatory bowel disease because that can worsen that. Any kind of obstruction or ulceration, anything like that, you would not want to aggravate the GI tract any further. Those would not be very good agents for that. Okay. Do I want to talk about the incretins right now? What do you guys think? Yeah, I see a lot of no's. You guys are paying for me to be here though, so I feel like I should give you your money's worth. Maybe even talk through lunch. No, I won't do that. Okay. So do you have any questions before I let you go? Just because this is kind of a big group and I kind of want to spend some time on this, so I end up going over. Any questions at all? Let me check the board.